Okay, Deirdre, I start, correct?
Correct.
Okay, thank you, Deirdre, and hello everyone there, all the panelists and all the attendees. I thank you very much for participating. My name is Nick Schwatt. I'm sitting here in New York, and I'm at Quadrus Medical Technologies, and this virtual mini symposium is on the clinical system identification. I have two slides literally just to show you, maybe to introduce it if people don't know what it is. And I'll start with that right now. So just remember, excuse me, that at the end we have a Q&A, question and answer session, an open discussion for an hour or a little bit more. So if you want to, if the questions are not related to the understanding of the material directly and they can wait, please leave them till the end. And at the end, we're going to have a long session specifically just to talk about the talks and the diagnosis in the 21st century based on clinical system ID. So we have plenty of talk for this, plenty of time for discussion at the end. Okay, so clinical system identification, for those of you who haven't heard of that term before, really is another way to do diagnosis. If it's clinical, then it's clinical diagnosis. System identification is a field that is 40 years old now, and it can be used, and it is used right now in some industries to do diagnosis. So how to extract some information from a system that you cannot necessarily get by sticking a sensor easily. It's an applied mathematics field, and it requires a lot of data, so data science gets involved also. So it is a geeky field in the heart of the clinical world. This is what we're trying to talk about here. This is what we work on, and we'd like to share some of what we do to you. Okay, this is one usage of clinical system ID. So basically, so we'd like to identify the health status of a patient, so we can help in better disease. DX means diagnosis of patient, that could lead to better therapy for the patient. Notice I say patient and not patients, because this is an individualized diagnosis and therapy. This is not the guidelines based. So those work as well. So this is another way to do diagnosis and therapy for the patients, basically. And it is at the core of personalized medicine. So according to us, this is what personalized medicine will be. So to have a personalized mathematical model that could mimic the real patient. So it is not based on statistics and guidelines, basically. It could be in some ways, but this is one usage that I work in. Okay, so it goes in two phases. Phase one is to obtain the personalized model. Typically, so if you have an organ, like a real organ, and you have a model, a mathematical model of the organ, the model can be simple, simplistic, or complex. The more complex is, the harder would be to personalize it. And a lot of times you can get away with a simple or simplistic model of the organ in order to personalize it. So it's much better to have a personalized, simple model than not to have one at all. So how do you do this? So the vitals from a patient and the vitals from a model, so blood pressure from the patient and the model, respiratory rate from the real organ and the model, they both go into an optimization box. So it's an applied mathematical field because we use optimization in order to fine-tune this model so that the vitals from the model will in time match the vitals from the patient. At that point, you could say, I have an organ model that's matching the real organ, so let me do what-if scenarios on the model of the patient rather than on the real patient. And that would be a big benefit for it. So phase one is to obtain the model and personalizing it via optimization. Phase two would be to use the personalized model. because once you have a personalized model of the organ, then you can do what if therapeutic scenarios to the personalized model. And wouldn't that be nice, so that we don't necessarily have to do it on the patient necessarily. First, you could do it on the model that mimics the patient, and then you can draw conclusions on what you want to do. These two fields are heavy in math and engineering. So we understand this is in the clinical field, but it's math engineering heavy. Since this is IEEE EMBS, I want to emphasize that math and engineering is certainly involved there. And what does the response, if you do what if therapeutic scenarios, do? It'll provide with better informed MD and guidance to better therapy that will together lead to better clinical outcome. That's why we call it clinical system identification. Okay, so that's the slide that I have. The next one, I just want to say thank you for the audience for coming, all the participants, all 70 of you. Thank you from all over the world. And the panelists, Leonard, Dan, Sid, Jason, and Rama, thank you very much for agreeing to do this and for sharing your experience with the audience and to highlight clinical system identification. And in EMBS, I'd like to thank Deidre, who showed up here to the meeting also at school, and Laura W. for allowing for this whole thing to happen. So as the agenda dictated, next is the talk by Dr. Leonard Leong. He cannot physically make it. He's a retired professor, but he sent me the video that I would like to play for you right here. He is, so he wrote the book on system identification. Literally, I use this book myself, and this is the video that I will play for you from him. Then we'll go on with the agenda.
Good morning. My name is Lennart Ljung from Linköping University in Sweden. I have been asked to kick off this meeting by saying a few words about system identification in the age of data science and machine learning. Data science is an important and slightly hyped topic in today's science and engineering. Wikipedia defines it as follows. To extract knowledge from data is really what science is about. So it is clear that this must be a central topic in science and engineering. In automatic control, we call the techniques to build models system identification. That is what has kept me busy during the past 50 years. System identification can be characterized by the following loop or flow. And that flow is basically the same in all of one model building, in all fields. We construct an experiment, or we observe an experiment that provides us with data. We also selected a set of candidate models, model set, where a model basically is a mechanism that allows us to have some opinion or prediction about the next observation based on what we have seen so far. We then select a model in model set guided by the data by optimizing the fits between the model and the data. Some sort of least squares fit between the model output and the observations are typically used. So with this model, we now have to validate it and see if it is useful for our purpose. It may very well be, depending on the outcome of that we have to go back and try a new model set or a new experiment before we are satisfied with the model. In this flow, the most important node is the validation. You see, the fit between a model and the estimated data can be very good in a large model set, where you have many parameters to adjust. Recall the classic quotation by John von Neumann: "Give me 4 parameters and I'll fit an elephant. Give me 5th and he will bigger his trunk." This means that the model must be confronted with a new validation data set that it hasn't seen before we can judge its usefulness. So how do we secure validated models? Well, basically, one way is to restrain the model complexity by restricting it to behave according to prior knowledge, which basically means that we build gray box models. The other aspect is to put parameters on a leash by not allowing them to run off unrealistically. Conceptually, you do that by adding to the model fits a penalty term on the parameters. This is called regularization, or kernel approach to the estimation. And the design of a kernel R is an important topic in today's system annotation research. And with that, I wish that we will have a productive and successful meeting today. Thank you very much.
Okay, so thank you, Leonard, and I hope everything goes well with your house in Sweden, whatever you're working on today. Next, probably we should go with Dan. I think will be next up. So you should be able to share the screen, Dan. Dan is an associate professor at Aalborg University in Denmark, and he'll share with us some of his work on clinical system ID.
Thank you, Nick. Could you, I think I need you to stop sharing before I can share.
Yeah, that's a good point.
Let's see. Well, thank you for the introduction, Nick, and thank you for setting up this symposium, and hello, everyone. So what I'll talk about is our research group's work with system identification of pulmonary gas exchange function. The background clinical problem is respiratory failure, and that is the respiratory system fails to either sufficiently oxygenate the blood and or remove carbon dioxide. And many of these patients end in the intensive care unit, which we have a picture of here to the lower right, which clearly shows a world ripe for system identification with lots of equipment, measuring data, and clinicians faced with complex decisions on a severe injured patient. Many patients with respiratory failure end in mechanical ventilation. In 2017, a bit over 1 million US patients with respiratory failure required mechanical ventilation. And in this group, a particular research focus has been in the acute respiratory distress syndrome, in short ARDS. And if we look at a recent study over 50 ICUs, roughly 10% of patients admitted to the ICU had ARDS, and these patients are quite severely ill with a mortality of around 35%. Why use system identification? Well, at the bedside, normally what measurements are available are at the mouth, measuring gases coming in and out of the patient, and then mostly in the arterial blood, so the blood leaving the respiratory system. But the issues within the lungs are very difficult to accurately separate using these more or less black box measurements. If we look at this schematic on the screen, we have the gas entering the lungs, and they can come into different types of respiratory units. The lungs approximately contain around 30 to 50,000 effective gas exchanging units. So we can say this is a simplification, but it overall describes the types of gas exchange problems that may occur in the lungs. So we have alveolar dead space, which is air reaching respiratory units that aren't receiving any blood flow. We have pulmonary shunt, which are units that are receiving blood flow, but no gas. And then we have the remaining units that receive some ventilation perfusion relationship. So a relationship between the amount of air entering the unit over time and the amount of blood entering the capillaries, reaching those units over time. And these units may then again have a degree of diffusion limitation affecting the gas exchange between the alveolar gas and the capillary blood. And it's not difficult to realize that if you're only measuring what you put into the lungs and what are coming out in the other end, it's very difficult to separate what part of this gas exchange problem is due to shunt, what part is due to ventilation perfusion mismatch, and what part is due to dead space, even though it's of course very valuable in determining that you have a problem in the first case. If we look at the golden standard for measuring gas exchange, it's the multiple inert gas elimination technique. It's a very complex model of the gas exchange. It has 50 compartments of VQ mismatch, and the result of such an analysis is shown in the three figures here to the lower part of the screen. And these are different patients, and each dot here is one of these 50 compartments where we see the ventilation, the open boxes, the open circles, and the perfusion, the blood flow with the closed circles. And then we see the matching across the different VQ ratios between ventilation and perfusion. And we have the two extremes, ventilation perfusion of 0, that is shunt, and ventilation perfusion of infinity, that is dead space. And they are rather detailed descriptions of the patients. They've shown us that we can see different patterns in patients. Patients may present with a shunt and dead space problem in particular. Patients may have low VQ mismatch, and patients may have high VQ mismatch, or a combination of them all. What multiple inert gas elimination technique also has shown us is that diffusion limitation is seldom required to understand lung gas exchange problems, except cases where we have pulmonary fibrosis during exercise or exercise during hypoxia. The issue with the multiple inert gas elimination technique, probably explaining why it hasn't seen routine clinical use, is that it is very resource demanding. It requires a specially trained set of staff. 6 different inert tracer gases must be infused into the patient, and then after 30 minutes, it requires simultaneous measurement of arterial and mixed venous blood, as well as expired gas of these 6 different inert gases, and then analysis using gas chromatography. So it's very resource demanding, both in staff, time, and equipment. But it has been definitely the cornerstone of our current understanding of lung gas exchange. So we are left with a problem of parsimony. We need to find a model that is sufficiently simple for us to be able to identify the parameters using bedside available data. Our proposal for such a solution is the automatic lung parameter estimator, in short, the ALPI. This is a model based on mass balance equations. I won't take you through the equations, but these are for oxygen gas exchange in the system. The model has 3 parameters: shunt, which is not oxygen responsive; FA2, which decides the distribution of ventilation between the 2 gas exchanging units, and then F2, which decides the perfusion, the blood flow between the 2 compartments. From FA2 and F2, we can calculate an index of low VQ mismatch, ventilation perfusion mismatch, called the delta PO2, which is oxygen responsive, and we can calculate the degree of high ventilation diffusion mismatch, delta P CO2, which is CO2 responsive. We identify these three parameters from weighted least square fitting to steady state bedside measurements that I'll show you here in the next slide. We use oxygen as a tracer, which means that we vary inspiratory oxygen, the oxygen the patient inspires, over 3 to 5 steps, this taking approximately 10 to 15 minutes. We then measure or estimate cardiac output as appropriate in the patient. And for each level of inspiratory oxygen, we measure using calorimetry, expired gases, and oxygen consumption and CO2 production, and oxygenation using a pulse oximetry measurement on the finger. Then we need one at least measurement of arterial blood gas to get the acid base characteristics of the patient. We have here 3 data examples. We have out of the x-axis, it's the end expired fraction of oxygen in the gas, and the arterial level of oxygenation in the patient. The points here show different steady state measurements in 3 different patients. The first line here is the model fit to measurements in a preoperative patient, more or less lung healthy, corresponding to, I hope, all of us attending here today. The next line shows slightly more ill patient in terms of gas exchange. This is a patient 3 days following surgery, where we have increased level of shunt and low VQ mismatch. And the last here is an ICU patient with ARDS with a severe level of shunt and VQ mismatch. And we can see here how this curve, the end tidal to arterial oxygen curve, is changing as these 2 parameters vary. And that's the source of our system identification, how we are able to identify the parameters. We know that shunt vertically depresses the curve, whereas low VQ mismatch horizontally displaces the curve. And it is this different response to oxygen as tracer that allow us to identify model parameters. In recent years, we have modified the model to also describe gas exchange of carbon dioxide. And this means that the data set has been added here to the right, describing CO2, where we know that the end tidal to arterial difference in CO2 partial pressure is an indication of high VQ mismatch. And this allows us to describe, to identify all 3 parameters, shunt, FA2, and F2. If it was oxygen only, we would only have degrees of freedom enough to describe shunt and either FA2 or F2, and the other VQ mismatch parameter would be locked. We showed in 18 ICU patients that if we had 1 parameter, 2 parameters, or 3 parameters, that we would have an increasing ability to describe oxygen and carbon dioxide gas exchange. And the 3 parameters, shunt, FA2, and F2, were necessary to accurately describe both gases in all patients. And that's what we're seeing here with the different curves, that the solid line is able to describe all measurements, whereas the dotted and dashed fail, representing one of the 2 other models. And if we take the shunt-only model, it is not able to describe gas exchange either. The system has evolved somewhat over the years. We have a set of pictures of the different versions. So this is the original 2002 version with a ventilator for gas mixing, a laptop, and a large Brill and Care gas analyzer. Quite a heavy setup to move around the ICU. Then the system with the commercial collaboration was developed into this preoperative device. The big box here holds a gas container for mixing subatmospheric levels of oxygen, which is necessary to accurately measure gas exchange in near healthy subjects. This was further developed into this device for use in the ICU, where we are not needing subatmospheric levels, but we can just vary the inspiratory level on the mechanical ventilator. And the most recent version is the Beacon Care system shown here to the right, where it's based on a tablet replacing the laptop and a small side-stream gas analyzer combined with a pulse oximeter. The LP method model, as well as estimation method, has been compared to the multiple inert gas elimination technique in lung injury models using a porcine model of a lung injury. In 7 pigs using oleic acid injury, it was shown that the partial pressure of oxygen was similar using the simple model in the LP system with the more complex model of Mikit technique, shown here that Bland-Altman plot with limits of agreement around 1 kilopascal, regardless of level, with some more inaccuracy seen in the high levels that are less relevant in the ICU. To the right, we see an example taken out of a total of 3 pigs, where the lung injury model was lung lavage, known to be a heterogeneous lung injury, whereas oleic acid is a homogeneous lung injury. Here, the simple model was able to describe, this is the crosses of the simple model, and the circles is measured retention of 6 different inert gases, and the simple model was able to describe these 6 gases, as is the basis for the multiple inert gas elimination technique. In terms of usefulness, the model has seen some use today, and mostly in 3 lines of research. It's been used for classifying and monitoring ICU patients. It's been used in the assessment of gas exchange function before, during, and after surgical intervention, and for standardizing and optimizing ventilator therapy. And I'll just give you 3 examples of those 3 lines of research. So for classifying and monitoring ICU patients, much of the focus has been on positive end expiratory pressure. That is the pressure maintained by the mechanical ventilator at end of expiration to maintain respiratory units open during expiration and prevent lung collapse. In the other end, when you increase PEEP, you also increase the top pressure, which may also cause some lung units to be recruited to be opened up and to be able to participate in gas exchange. We did a recent study in 12 ARDS patients where we did a recruitment maneuver followed by PEEP of 5 and then either 15 or 20 centimeters of water. We then at each level measured gas exchange function by the ALPI technique. And then we also did CT scan analysis at each PEEP level. And we see here in 1 patient example, the CT scan at 5 centimeters of water and at 20 centimeters of water. And the white or light gray areas here are the regions of lung collapse. And we can see how at 5 centimeters of water, these regions are are larger than at 20 centimeters of water. So going from 5 to 20 centimeters of water of PEEP opened up and kept open a portion of lung regions. Using Hounsfield units, this can be translated into an estimation of lung units that are hyperinflated, normally aerated, poorly aerated, and non-aerated. And in this study, we wanted to compare these different categories of aeration with the gas exchange measurement using the ALPI technique. From the gas exchange responses, we identified 3 particular responses. We had a very positive response, which was a reduction in shunt with no change in high VQ mismatch, which was hard to characterize as anything but a good response. We had a very negative response in some patients where both shunt and high VQ mismatch increased when we increased PEEP. And finally, we had a group of patients where shunt was reduced, but high VQ mismatch was increased. So here we have a balancing between improving oxygenation by lowering shunt, but worsening CO2 exchange by increasing high VQ mismatch. This was not a new finding. Previous studies using the multiple inert gas elimination technique has shown similar responses, which was just a sort of verification, at least, that this could occur. But we could not identify these 3 responses using aeration analysis from the CT scans. which is perhaps not so surprising because aeration is only based on ventilation, and gas exchange function is from the matching of ventilation and blood flow in the different gas exchanging units. A recent publication investigated the use of ALPI during surgery to guide the selection of PEEP in patients undergoing one lung ventilation. PEEP was selected to minimize driving pressure. That's the difference between the top plateau pressure and PEEP, using two strategies, either a decremental, where PEEP were decreased in steps, on incremental, where with stepwise increases in PEEP. Both strategies resulted in significant changes in shunt, but driving pressure was lower using the decremental strategy, even though it resulted in similar changes in shunt, causing, of course, the conclusion to be that probably decremental PEEP strategies should be advised in these patients. And challenge when using these new physiological parameters at the bedside can sometimes be that it requires a physiological insight not always available to the clinical staff at hand. And one of our solutions to that is to integrate this system identification in a system for decision support. And the Beacon Care system both have physiological models that are identified, tuned to the individual patient, combined with utility theory to decide which levels of settings on the mechanical ventilator is best for the individual patient. So we use very much, as Nick was saying in the start of this symposium, system identification to personalize these physiological models to the individual patient. And if you have fitted, tuned, using system identification models to the individual patient, those models can be used for the phase 2 prediction of how the patient will respond to changes in care. And this allows, when combined with utility theory, the system to try all the possible angles of mechanical ventilation in the patient without causing any harm to the patient, to select the best compromise between the conflicting clinical goals that are associated with managing mechanical ventilation. And we're currently at the level where we are going to analyze results from randomized clinical trials using this decision support system. And a brief outview, because there are still plenty of clinical challenges and unmet needs in, for example, the ICU. We have doctors only visiting periodically. Of course, they can't be there 24/7, and they need to make life-critical decisions based on patient data, patient history, best practice, as well as clinical experience. But it's very well known that experience and expertise, as well as time available, varies considerably between doctors. And we have a necessity to consider all the different organ systems in these patients, which are normally compromised, at least to some extent, in these patients. And we believe that SystemID is a powerful tool to enable integrated solutions where we can integrate data from these different devices available at the bedside to allow more in-depth physiological monitoring and using these models to provide intelligent, personalized advice on care for the individual patient. Thank you.
Okay, can you hear me now? Yeah. Thank you very much, Dan. Dan is an associate professor again at Aalborg University in Denmark. Thank you very much for this talk. Okay, and you finished right on time, actually. So according to our agenda, the next talk will be by Mr. Siddharth Chavarti. He's a research engineer at Quadros Medical Technologies. And I put 5 minutes in between the talk thinking that people will need to adjust, but younger people just do it instantaneously, so we don't need the 5 minutes anymore. Anyway, so Sid, did you stop sharing, Dan?
I need to figure out how I get back to that screen, sorry.
Yeah, it's okay.
We have 5 minutes.
Yeah, we do have 5 minutes for that.
I have 5 minutes to figure it out.
Yeah, that's right. I think from the attendees, you can either write your questions now or save them till the open discussion. If you write them now in the chat box, I can write them down on a book that I have here, and then I can ask them for you in the open discussion. Otherwise, you can ask them yourself at the end during the during the open discussion.
Well, I can bring out your screens, but I cannot bring out the screen that allows me to stop sharing. So I don't know, it's somehow locked.
Oh,
I can, of course, leave the meeting and rejoin. That's a practical solution. Why don't I do that?
Yeah, I mean, if you hover on the top, you have like a small band.
Oh,
on
it's
top.
there. It's on the shared screen.
Okay, okay, good.
So,
Yeah,
sorry.
good. No, it's okay, it's okay. That's why we put 5 minutes. Cool.
Yeah.
Thank you, Dan.
I just wanted to
Dan.
demonstrate it. Yeah.
Yeah, that's right. Exactly. Okay, nice work. Thank you.
Okay. Oops, sorry. Hi, can everyone hear me well, panelists? Okay, so hi, my name is Siddharth Chavarti, and I am a research engineer at Quadris Medical Technologies, and I work on the research and development of advanced algorithms and system identification in medical devices like the ventilator. Today, I am going to talk about system identification of the parameters of the lung and how it can be used to improve the performance of modern day ventilators and keep track of patient health. So let's dive into it. So let's start with, let me ease you guys into what a dynamic system is. I would like to begin from there. A dynamic system can be described using parameters and variables. Now, parameters, as you see here, are those quantities that describe the material property and geometry of the dynamic system. For example, in a clinical scenario, stiffness of the lung or stenosis in the aorta, and maybe resistance inside the airway, etc. On the other hand, variables, as you see on the side, they capture the behavior of the system to different input perturbances. For example, cardiac output, blood pressure, respiratory rate, etc. Now, system identification is the process of building these mathematical models using variables that we can measure to estimate parameters that we really cannot measure. Like, there is no way we can measure the stiffness of the lung. It's difficult without invasively sticking a sensor into the dynamic system. Now, the first step, or one of the most important steps of system identification, is figuring out the structure of the mathematical model. Now, this can be got by assuming first order principle. Like, if you know the physics of the dynamic system, you can use first order principle models. Like, here are a few examples: a nonlinear pressure flow relation, delta P equal to KQ square, or the first order lung mechanics equation, which is mouth pressure divided by lung pressure, is 1 by tau s plus 1, where tau are the parameters of the lung. Or even the simplest, force is equal to mass times acceleration. If you do not know the physics of the system and you just want to use system identification to capture the dynamics, then you can use other models, like just a generalized polynomial model or an autoregressive model. And if you want to capture nonlinearities, you can use a nonlinear autoregressive function. You can also use transfer function models, like there are Box-Jenkins models, and this keeps going on. You can keep creating models. So let's move on then. Now, just to give you a background of what I'm going to talk about during this presentation. In this presentation, my dynamic system, as I mentioned before, is the human respiratory system. In a clinical scenario, we aim to estimate the parameters of the patient lung by using ventilator variables like pressure and flow. Here is an example of a ventilator schematic, where from the ventilator, there will be tubes that are connected to the mouth of the patient. We measure the pressure. The pressure is measured by the ventilator inside the device, and they assume the pressure at the mouth, and hence, and they try to control the pressure in the lung. Now, we want to estimate the parameters of this lung using the variables that are already measured, essentially the pressure, the mouth pressure, and the pressure inside the ventilator. Now, by estimating the parameters of the lung, we can build math models which can emulate the dynamics of the lung. This math model can help and aid in the diagnosis of patient disease and keep track of patient lung health, and hence enable the optimal ventilator efficiency and increase we can save more patients' life essentially using system identification. Now, how we apply system identification. In a ventilator environment, system identification can be applied in a scenario where dynamics does not change in time, and also it can be applied in a scenario where dynamics changes in time, like as the ventilator is ventilating a patient's lung, the parameters of the lung keep changing in time, and we can use system identification in real time to see how those parameters are changing. And in an offline scenario where the tubes are pretty much the same, like the tubes that connect the ventilator to the patient are pretty much constant across all patients, those dynamics can be captured in an offline scenario and just used in the whole scheme of things. Next, let's go. So here is a typical example of offline system identification. Now here in this system, my dynamic process is air flowing through the vent tubes to the patient. So the air comes out of the ventilator exit and goes into the patient's mouth. This is usually modeled using nonlinear physics. Since this is a corrugated tube, it has surface roughness, which can cause turbulence. And according to physics, we know the way fluid dynamics works, and there is a nonlinear relation. And there's also a storage device in between. There's a humidification chamber, a humidifier, essentially a humidifier. And how humidity varies causes variations in the flow patterns is another thing we have to model. Now, but really when you look at it, an important step in system identification is to always look at the data that you collect. So in this scenario, we collected the data that was collected in the data from the ventilator and the data at the mouth of the patient. And we noticed that, so let me explain this plot. In this plot, the blue color line represents the pressure at the mouth, and the red color line represents the pressure of the ventilator. And as you can see, just by looking at the graph, that the transfer function that converts the mouth pressure to ventilator pressure is just a gain. It's as simple as a gain, not a complex transfer function model or some fluid dynamic equation. So yes, this is an example on offline system identification. Now, when we move on to real-time system identification, essentially identifying the parameters of the lung, as I've mentioned in the previous slide, where we want to capture the changing parameters during a ventilation phase in a clinical scenario, we would first need to identify the lung mechanics. The first step to identifying the parameters of the lung is to figure out what the model structure of the lung is. The lung can be modeled. Lung has been modeled as a balloon in a jar, where the jar is the pleural space and the balloon is the lung. Now, PAO, as you see here, is the airway pressure. PAL is the alveolar pressure. PPL is the pleural pressure. PMUS is the respiratory muscle pressure. And V dot is the flow that goes into the lung and comes out of the lung. Now, as Nick has taught me, he has taught me that we have to use linear graphs. We can use linear graphs to show lung mechanics equations, the dynamic equations of the lung in terms of, you can capture the dynamic equations of the lung using linear graph. Now, here what happens is we derive the equation of motion of the lung, which is delta P which is equal to resistance times flow through the lung, through and out of the lung, plus elastance times the tidal volume, by using the Kirchhoff voltage law on this simple linear graph circuit. And for our experiments and further for the rest of this presentation, we assume that the patient is sedated, so the muscle pressure is 0. So now that we have got the structure of the lung, we ran the structure of the lung. As you see here, it is the model structure is delta P is equal to R times Q and E times V, where R is the resistance, which is the resistance to airflow, which is a parameter of the lung, and E is the elastance, and we take it as compliance, which is 1 over E, which talks about how stiff or how stiff the lung is. Now, why do we have to estimate these parameters? These parameters are very important because they can aid in the diagnosis of patient lung disease. Further, the generated mathematical model with the estimated parameters can be used by medical doctors and physicians to assess therapy options to improve lung health. On the right here, you can see that for the experiments that we performed of clinical system identification, we used a lung emulator. And the lung emulator has different resistances and compliances that vary from 5 to 50, and compliances range from 50 to 10, which is most compliant to least compliant, or most stiff to least stiff. So the experimental variables that were captured were from the flow sensor, which you see here, a black color device, and the pressure sensor, which is a tube that's attached at the mouth of the quick lung or the lung emulator that goes to a pressure sensor. The experimental variables are mouth pressure, lung flow, and tidal volume that is computed from the lung flow. The lung parameters that we are trying to estimate are resistance and compliance. The estimation methods that we used were least square estimation and iterative optimization. The experimental setup was the first we first gathered data for a duration of 10 breaths across 8 ISO tests. Now, let me give you a small outline of what ISO tests are. ISO tests are the tests that are given by the International Standards Organizations for ventilator testing. They have a table where they change the R and C's to see the performance of the ventilator. So we tried to follow, since our application is to implement this in ventilators to improve performance, we tried to follow those standards and do our testing accordingly. The data was collected at a sampling time of 10 milliseconds. We also did a real-time setup where we connected our algorithms to the ventilator and started looking at how the estimation is performing over time. The parameter estimation in the least square approach was done with a window size of 200 data points, which is approximately 2 seconds of the breath, and the window step moved by 1 sample point every time. So R and C were computed for 200 points with basically a window that was moving at 10 milliseconds. Let's move on then. So now I will talk to you about the results of what we have achieved from there. So first, we did the offline experimental setup. We applied iterative optimization and least square optimization, least square estimation. On the left side, you will see 2 graphs that depict the results which we have got. The first graph on top compares the resistance to the isotest number and resistance to isotest number, and the second one is the compliance to isotest number. So the blue markers are the actual resistances that have been set on the lung emulator, and the green markers are the estimated resistances due to least square estimation, and the red markers are the iterative estimation due to iterative estimation, basically. And then again, the same follows on the compliance. The blue is the actual set, the green is the least square estimation, and red is the iterative optimization. Now, here are the results, and we have noticed that the iterative optimization performs much better compared to the least square estimation across all the isotests, across 8 isotests. And the way we performed the least square optimization was, the iterative optimization was just, we picked the appropriate objective function, which would be our lung model and relation with our mouth pressure. And then theta covers all the parameters that we want to estimate, which can be R, C, and we can even do PMUS depending on the type of optimization approach. Lambda is the step size, and D will be the search direction, usually the gradient. We also performed offline least square estimation versus real-time least square estimation because we wanted to see the effect of collecting data offline, performing an estimation on that versus actually having a moving window in real time. And while the lung emulator was on ventilator support, and we noticed that there was not any significant increase in performance between an offline least square estimate versus a real-time least square estimate. And this is where we went back to our previous conclusion that the iterative approach was a much better approach, and we should implement that in the real-time system to improve performance of ventilators and keep track of patient lives. All of these methods are currently in R&D phase with our own Quadrus ventilator, and the clinical testing will be done probably in 2022, where we can start proving the feasibility of how these can help keep track, assist in diagnosis of patient disease and keep track of patient health. One interesting fact of real-time system ID is that when parameters, like as I told you before, in real-time system identification, the parameters of the lung keep changing during ventilation. Like it's very important to keep track of whether you're improving the patient health or just making them worse. So here is an experiment where we changed the parameter of resistance from R equal to 5 to R equal to 20. And this is where you see the step given. And this is our estimate, a real-time system identification estimate. And we saw that at the second, the R changed using all the variables we had in the system, basically pressure, flow, and tidal volume. We were able to capture a change without having a change in C. So our estimate, we did not change C across these two systems. So we did not expect a change here. And this shows that this strategy of using system identification in real time to capture patient health improvement or seeing whether we are causing issues to the patient lung is good, because we are able to capture the change in parameters over time. This is nearing the end of my talk, and I really want to express the usefulness of clinical system identification. And it's very important that we as a community of engineers and mathematicians can help in do our part in helping save patients' lives. And a few ways is like how system identification helps. It removes the need of invasive sensors. Imagine having to put a sensor just into your body to measure the stiffness or the thickness of your chest wall or the stiffness of the lung, or figure out what the resistance in the airway is. That's just so invasive. When you can do it with math, why do you have to do all that? It enables estimation of unobservable variables and parameters, which is what I just explained, like stiffness of the lung and resistance in the airway. The main potential in the system identification is to identify and track patient health, because the identifying and tracking is essentially trying to figure out the parameters of the patient's physiology and then using that to create math models. Those math models can help in the diagnosis of patient disease. And also these, as Nick explained in his slide on phase 2, where you can use these math models, give therapy options, see the response of the system, and decide whether that therapy is right for that math model, not the real patient, math model. And again, all this is for a patient, and this is a major step towards personalized patient care, which I think is game-changing in the field of medicine. And finally, I would like to thank the entire Quadrus team, Pratap, Caitlin, Nick, and my fellow speakers, and IEEE EMBS for allowing postings. Also, thank you, audience, for listening in. That's it.
Okay. Okay. Can you hear me, everyone? Again? Yeah, right. Okay. Okay, no problem. Thank you very much. Sid is a research engineer at Quadrus Medical. Next is Professor Jason Bate. He's a professor of medicine at the University of Vermont, and he'll give us his talk. You are allowed a couple of minutes to look for the right things, Jason, should you need it.
Okay, I'll start looking right now. Let me see if I can find on my screen.
Yeah.
Can you see that? It's a
Yes.
PowerPoint presentation.
Yeah. Uh-huh.
Okay. Open it up in presentation mode. Can you see it in presentation mode?
Yeah, now we can.
Yeah, and you don't have the summary slide. It's just the presentation. It's not slides, the notes and all that kind of thing.
Yeah, but this is not the first slide that we see now. So you have to scroll up.
You're right. Sorry.
It's okay.
First slide. There we go.
Yeah, exactly. Uh-huh.
Yeah. Sorry about that. Okay. So
It's
that's
okay.
good.
It's okay. Whenever you're ready. Whenever you're. I mean, if you want to also give it a minute, you can. But if you're ready, we can go ahead.
I think I'm ready.
Okay. Cool.
Great. All right. Well, thank you very much, Nick, for inviting me to take part in this very interesting seminar or mini symposium. And it's nice to see some of my colleagues, especially I would say Dan Carbing, who's the other side of the Atlantic. I haven't seen him for a few years, but it's nice to meet this way. So I'm going to talk about application of system identification to the diagnosis of lung disease. And in many ways, it follows on very nicely from the talk that Sid just gave, because it's in a similar kind of area. But my emphasis is going to be rather on diagnosing what's wrong with the patient, as it's more about figuring out what's going on in disease. So I spend most of my time using system identification in the lung to try and understand disease pathophysiology. What I'm going to talk about today relates to asthma, but I do this a lot in acute lung injury as well. And the reason why we want to find out what's going on in asthma is because we actually don't know. Asthma is still a very mysterious disease, despite having first been described by the ancient Greeks, I think about 2,000 years ago. We're still trying to figure it out. And that's simply a testament to the fact that it's very complex and not the same in any one person. Anyway, the basic anatomy of the respiratory system looks a little bit like this. You have the lungs and the chest wall, the diaphragm, and so forth. That's the sort of thing you might see in a textbook. But in its details, it's exceedingly complex. So here's a picture of a karst in the human airway tree superimposed on an X-ray. So if you look at the airways, starting with the trachea at the top and branching into ever smaller branches, it sort of reaches the far reaches of the lung, and it's exceedingly complex. And if you go down to the end of any of those airways and look at the alveolar tissue, you'll see something like this under the scanning electron microscope, where you have tiny little alveoli that are a fraction of a millimeter across, and there are about, the anatomists tell us, 300 million of them in a single human lung. So it's a very complex structure. And to do system identification on this, and I'm talking today about the mechanical properties, we need to have some kind of model of this structure. And system identification models always have to be simple. They have to be characterized by small numbers of parameters, because otherwise you're never going to be able to uniquely identify those parameters from any given data set for all practical purposes, no matter how accurate it is. Still, some very simple models can be useful. So here's a really simple model. We heard about this one before, just from Sid. So if you imagine that the elastic expansile tissues of the respiratory system, the lung, the parenchyma and the chest wall and so forth, can be represented as a couple of sliding canisters that increase their volume by the top one moving up relative to the bottom. And I put a spring between connecting the upper and lower portions of that, so that as the volume in that unit expands, the spring gets extended and it generates a recoil pressure inside the unit. And it is served down the bottom there by a single conduit representing the airways. So we've taken all those incredibly complicated airways and represented them by one pipe, and all those gazillion alveoli and represented them by one unit. And if we imagine that if we were to look at the relationship between the elastic pressure in that unit and the volume applied to it, and we would get a straight line going through the origin, that line is characterized by a single parameter, namely its slope, and we call that E, or the elastance of the lung. And the same thing for the pressure drop delta P across that conduit, giving us the resistance of the conduit. And that structure then has a very simple first order linear differential equation of motion, which says that the pressure you apply to it is equal to the sum of the pressure drop across the pipe plus the elastic recoil pressure inside that unit. And it's characterized by two adjustable parameters, E and R, just as we heard about before, elastance and resistance. Now, that incredibly simple model, a lot of the time, works surprisingly well. So here's some data shown in the light circles there of flow, volume, and transpulmonary pressure in a mechanically ventilated patient. This is actually the ensemble average of a minute of regular breathing. So there's breath averaging going on there. And the best fit that I can get from that simple model is shown in the third panel down, transpulmonary pressure, which is the difference between the pressure in the trachea and in the esophagus. The best fit I get is by that dark line, and you can see it's pretty good. It accounts for most of the variation in the data. And in fact, the residuals, the difference between those two curves shown at the bottom, it's just got a few lumpy things there, and those are cardiogenic oscillations for the most part, due to the heart hammering the lungs every time it beats, and that's not incorporated in the model. So most of the mechanical properties of the lungs are actually accounted for by this incredibly simple model. Doesn't mean the model's right, of course, it just means it does a good job empirically of characterizing those data. Now we go a little bit further in our investigations, our preclinical investigations of what's going on in the lung and disease by calculating lung impedance. And this is straight out of system identification as an engineering discipline. So we assume the lung is a linear dynamic system. We excite it with some broadband input and flow. We measure the pressure as the output. And then we take the Fourier transforms of those two signals, and we assume that the transform of the pressure is related to the transform of the flow, V dot, by this complex factor called Z, called lung impedance. And so you can calculate impedance by taking in the frequency domain the ratio of pressure to flow. There's a few details involved in that, like windowing to average out noise and all that kind of stuff. But this is where we've put in an input, we've measured the output, and we're trying to figure out what's going on inside the lung, and we characterize it empirically in this particular case as this thing called impedance. And this is the precise analog of electrical impedance, where you'd have current and voltage, or any other kind of mechanical impedance like velocity and force. Here, the lung analogs of these things are flow into the lung and pressure across the lung. So the impedance of the basic model here, the one that I showed you before, that has an airway resistance and a tissue elastance, it's got a real and imaginary part. The real part's called resistance, the imaginary part's called reactance, and that, of course, is √-1. The impedance of that model simply looks like this. The real part is the resistance of that pipe, which is why that real part by respiratory physiologists is called resistance. And the reactance for this model is a negative hyperbolic function of frequency scaled by the elastance of that spring. Now, most of my work over the years in this area has been done in animal models of disease, mouse models of disease, to be precise. The device that we use to do that was developed in my lab about 25 years ago when I was at McGill University. And it is a computer-controlled mechanical ventilator for small animals, which is now marketed by a company called Cyrec, and it's called the FlexiVent. I started the company, but I have nothing to do with it now, just full disclosure. But it's been gratifying to see this device used all over the world in many, many labs in order to study lung function in mice, because that's a bit of a technically challenging thing because mice are so small. But basically, it's a computer-controlled piston oscillator. It measures pressures and displacements. And by doing various dynamic calibrations of the device itself, it's able to calculate the load impedance that you attach on the end of it, i.e. the mouse. Now, the model that we use to characterize mouse impedance between 1 and 20 hertz is a little bit different to the one I just showed you. It was put on the map about, again, 25, 30 years ago by a Hungarian biomedical engineer, Zoltán Hantos. And again, we assume a uniformly ventilated lung with an airway resistance. But now the tissue that gives rise to elastic recoil is characterized by two parameters, G and H. And the functional form of the impedance looks like that. It's a little bit weird because you'll notice that G, which is essentially tissue resistance, and H, which is the equivalent of elastance, have the same ratio independent of frequency. And so this is called the constant phase tissue model. But there's an alpha parameter on the bottom of that second term. And over to the right there, you see alpha depends on H and G. So it's a very interesting model where, in fact, the units of G and H depend on their values because they determine H. There's a little trick you can do to get away with it, to get around that. And for functional purposes, it doesn't really matter. But the physics of the tissue that's giving rise to that particular functional form is a very interesting topic in its own right, which I don't have time to get into. But it's related to the fact that if you take a strip of lung tissue and suddenly stretch it and look at the stress in that tissue as a function of time, it doesn't decay exponentially or even as a sum of exponentials. It decays as a power law in time. And that's all I've got time to say about that, but it's a pretty interesting physics going on there. So this is what, in the symbols, the real and imaginary parts of impedance over that frequency range look like when you measure it in a mouse. And that's the fit achieved by that simple model that has only 3 parameters. So from the point of view of parsimony, it's a pretty effective model. So there it is again. Now, it turns out that that resistance parameter is a useful estimate of the airway resistance, of the resistance of the airway tree. And we know that from experiments that have been done using alveolar capsules, where you measure pressure directly on the surface of the lung, looking down at subpleural alveoli, from which you can calculate airway resistance directly. And when you do this many times, comparing alveolar directly measured airway resistance to that resistance parameter up there, there's a bit of scatter because the lung's not perfectly homogeneous, but they lie pretty nicely around the line of identity. So we've always used R sub n, which means Newtonian resistance, as a useful estimate of the resistance due to flow of gas through airways in the lung. And that's important because there's a lot of resistance associated with movements of the tissue as well. They have viscoelastic and dissipate energy. So when we fit the constant phase model to a measurement of impedance in a mouse, we get an estimate of airway resistance. We get this thing G. We call it tissue damping sometimes. It's related to the rate at which energy is dissipated in the tissues as they are stretched, and then we get a measurement of lung stiffness. So if you do an intervention and you see that resistance parameter go up, it's a pretty good indication that the airways have narrowed. So if you're simulating an asthma attack, that's what you'd expect to happen. If G and H go up in the same proportion, that's a pretty good indication. It doesn't prove it, but it's a good indication that you have de-recruited some fraction of the lung. It's just closed down and now no longer takes part in the activities of the lung. It's just been shut off. You have a smaller lung. And that is a very typical situation of what happens in acute lung injury models. So we use that to figure out how much lung has been de-recruited when we induce lung injury, for example. And it also turns out, again, for reasons that are pretty established, both experimentally and theoretically, but I don't have time to go into, that if that G parameter increases proportionately more than H, that's a marker of the onset of regional ventilation heterogeneity throughout the lung. So here's a mouse model of asthma. And I put asthma in quotes because we don't really know what asthma in a human is. So to say that we're creating it in a mouse is a little bit presumptuous, but you've got to start somewhere. And this is work that was done back in the early 2000s when I first started looking at this. But this is a very standard way of making a so-called asthma model in a mouse, where you basically expose it to a foreign protein, essentially chicken egg white, and you get the animal to mount an allergic response against that. And then when you challenge the animal a few days later with the same protein by nebulizing an aerosol into their lungs, they generate a sort of generalized inflammatory reaction in the lungs. Inflammatory cells move in, they produce more mucus and all that kind of stuff. And then you can do an experiment shortly after that and find out that they are in fact hyper-responsive to challenge with methacholine aerosol, which is a standard procedure that is used to test human asthmatics to see if they are developing asthma. So here what we did was we subjected mice to about 40 seconds of methacholine challenge and then turned the methacholine off at time 0 here. And for the next 3 minutes, followed the progress of that RN parameter. So the animals were just mechanically ventilated over this time, but every 15 seconds or so, was it 15 or 20 seconds? I can't remember. We would switch the ventilator from ventilating into oscillating. And that's what this FlexiVent can do. You can interrupt ventilation anytime you want and use it as a system identification test bed. So we would pull off an impedance measurement in 2 seconds, about every 15 seconds. And from that, estimate those 3 parameters of the constant phase model. So this is what the Newtonian resistance does as a percentage of its baseline value. So it peaks out pretty quickly and comes down to a plateau, which will just sit there forever until you do a big inflation of the lung, and that will pull the values back down to baseline again. So when we compared non-so-called asthmatic mice to asthmatic mice who had inflammation, we find that the asthmatic mice are hyperresponsive to methacholine, which is really the reason why people call them asthmatic mice. When we look at the tissue resistance parameter, G, we find a similar kind of effect, except that the difference, certainly in terms of the plateau, is more accentuated. But when we look at the lung elastance, the stiffness of the lung, we find that this is where the action is in terms of difference between the allergic and the control animals. They get much stiffer, and the plateaus don't show this initial peak here, but they just go up and sit at an elevated plateau. Now, in order to try and understand this, we used another very powerful tool that can be used alongside system identification to try and help you understand what's going on. And that is kind of the inverse of it, or simulation, or forward modeling, if you like. So I, at the time, got the best anatomic data I could about the airway tree structure of the mouse lung. I created this in the computer, and I put terminal elastic units on the end of all the terminal airways. I used standard physics equations to calculate the airway resistance of every branch. I assigned a constant phase impedance to every unit, and I just added up all those impedances to figure out the impedance of the entire lung. And then I said, okay, how do I make this lung behave the way we observed in the lab? So I just had the airways of those lungs all narrow by a fixed percentage in order to force the change in airway resistance to match what happened experimentally. So the simulation in red, experimental lab observations in black. But when I did that, I found that, first of all, G wasn't too bad. The tissue resistance wasn't too bad, although it missed the peak. But the model failed miserably when it came to looking at the stiffness. The stiffness went up in the control animals, didn't change in the model. And why would it have? Because there's nothing in the model that would change stiffness. And this, by the way, is an example of the best case scenario when you're doing inverse modeling or system identification, if you're trying to figure out some basic physiology. The best case scenario is that your model doesn't work. Because when your model doesn't work, you know there's something you're missing and you have to go and find it. When your model does work, all that means is you know it works. You don't know whether you were lucky, whether it's actually correct. You don't know anything. When the model doesn't work, then you're going to learn something. So we had to figure out why this prediction of stiffness was not working in the model. And we didn't have to think very hard about this, actually, because what happens in inflamed airways, if you look at them in cross-section, is that they can become, the liquid lining layer can become unstable and glop across and form a plug. And that de-recruits the downstream segment of the lung. So in other words, that lung checks out and can no longer contribute to the impedance that you're measuring. We also use micro CT to confirm this directly by looking at regions of the lung that dropped out when this happened, by having them breathe pure oxygen, having that oxygen resorb, and then scanning the lungs and basically seeing how much looked like liver. And the fractions of lung that we lost in this way were almost unbelievably close, in fact, to the changes in stiffness that we measured. So this is a pretty direct demonstration that we're getting closure of small airways when we give this methacholine challenge. And that was easy to put into the model. I just said, okay, find some airway radius, which happened to be 35 microns. And anytime an airway in the model gets less than that, close it and keep it closed. And when I did that, the match to the airway resistance didn't change. The match to the tissue resistance got a little better even. And the match to the tissue stiffness was perfect. But when I did the same game, played the same game with the allergically inflamed animals, forcing the airway resistances to match, again, the model failed. The simulations were too low in terms of the tissue resistance and the tissue elastance. Again, we got to learn something. And what we eventually concluded was that what happens in inflamed animals, if you look at a slice through the lung compared to control, is that the airway lining actually gets thickened. It gets full of mucus and just generally inflamed. So again, I put a lining in the airway, inner lining in the airways of all the lungs of 20 microns, found by trial and error. And I increased the closure radius a little bit to account for the fact that there's more mucus in an inflamed lung. And when I did that, the matches got really good. So this was pretty interesting because up to that point, people had presumed that these allergically inflamed animals were hyperresponsive to methacholine because the airway smooth muscle was stronger, twitchier. There was something to do with the smooth muscle. What this shows is it's got nothing to do with the smooth muscle at all. The smooth muscle is perfectly normal. It's just operating in an abnormal lung, which has got a thickened airway, extra secretions. But the plot thickens a little bit because we then went ahead and looked at what happens when we give the methacholine to these animals by injection, intravenous injection, rather than aerosol into the lungs. To analyze this, I came up with, in many ways, an even more presumptuously simple model where I model the lung or the airways as a single tube embedded in elastic parenchyma. And the thing is that when you increase the lung volume or the transpulmonary pressure, that parenchyma pulls outwards on the airway wall and loads the smooth muscle so that when you get a hoop stress, FP generated by, to constrict the airway, the outward pull of the parenchyma opposes that. And this is modulated by changes in transpulmonary pressure. And there are equations you can use to account for all that. And I also had to put dynamics into the model because when you give an injection of methacholine, the airways contract dynamically over about 20 or 30 seconds. And so I put the classic hyperbolic force-velocity relationship into smooth muscle to account for that. And so now what we have here is a broadband volume signal and its corresponding pressure signal over 20 seconds, measured at the entrance to a mouse, while following at T0 a sudden injection of methacholine. What you can see is the volume signal posed by the ventilator is basically pretty much the same, but the pressure signal is getting bigger and bigger in amplitude. And the repeat period of that is 2 seconds. So within 2 seconds, I calculate impedance and fit this model, estimated these 3 parameters. But then we moved this sliding window across the data, and by tracking this RN, could get a dynamic estimate of how airway resistance is evolving over time. And when you do that at 3 different inflation pressures, a low, a medium, and a somewhat high inflation pressure, so that the lung is at different volumes. At the high inflation pressure, those parenchyma are pulling out on the airway and stopping it contracting. You can see that it modulates the change in airway resistance quite dramatically. And I fit the model simultaneously to all those 3 measurements, and it fits pretty well. from which you can estimate things like the maximum force of the muscle and the asymmetric force, rather, the maximum velocity of contraction, and the parameter which characterizes the stiffness of the airway. And that was the original purpose of this particular study, to estimate the stiffness of the airway. But what we found was kind of interesting. These are the changes in resistance that like I just showed you from the control animal. Here on the same scale are the changes in resistance in an allergically inflamed animal, and they are much bigger. Now, this is airway resistance. So this indicates that the airway smooth muscle is actually responding more in these animals when they're allergically inflamed than when they're in controls. And in fact, when we gave the control animals 3 times the dose of methacholine, it looked somewhat similar to the allergically inflamed. So now we seem to have a conundrum, because the allergically inflamed animals, when they're given injected methacholine, look like the airway smooth muscle is hyperresponsive, as I just said. But if you remember previously, when I was talking about the same animal model getting aerosolized methacholine, it looks like the smooth muscle is normal. So what's going on here? Well, our hypothesis is this, that when you give methacholine by aerosol, it's got to get into the airways, cross the airway wall, get into the tissues, and then get into the smooth muscle. When you give it by injection, it comes in via the vascular, crosses the endothelium, and gets to the smooth muscle. Now, allergic inflammation creates mucus in here. And that, if anything, increases the epithelial barrier. But inflammation makes endothelium leaky. It's one of the things that happens in inflammation, so that mediators and blood cells and so forth can get into the tissues. So when you give by injection, more of the methacholine gets to the smooth muscle relative to when you give it by aerosol. So here again, the hyperresponsiveness that we're seeing has got nothing to do with the smooth muscle per se. It's a delivery issue, which again is not something anyone would have figured out unless we'd gone to these details using computational models and impedance measurements. It's a fairly sophisticated system identification to figure this out. So you can say that when an airway embedded in parenchyma goes from relaxed to contracted, there's all these factors that can be responsible for how much it contracts, like the parenchymal tethering from the airways may be reduced. The smooth muscle may be stronger, but it may also have increased stimulation because of increased delivery. And you can also have thickened airway walls with inflammation and edema. Which of these is relevant in human asthma? Well, it depends on what situation you're talking about, because there are different flavors of asthma. And really the answer is all of the above in varying combinations, depending on what particular pathology you're talking about. But it's an interesting and complex situation. And moving forward, we may be able to, in some way, use these kinds of system identification methods to figure out what's happening in human subjects. And finally, I'll just say, along those, in that vein, what we're doing right now is using these system identification methods to study the asthma of obesity. Obesity is a big problem, of course, not just in this country, but in the world, and getting worse. And it impacts pretty much any chronic disease you can think about, including asthma. And interestingly, there's a particular kind of asthma which is not associated with allergy and develops later in life, which seems to be specifically related to obesity. Because it's been shown when people get bariatric surgery and lose a lot of weight, they tend to recover from this kind of asthma. But it's pretty mysterious as to what's actually going on, but the presumption is it's got something to do with chronic compression of the lungs, forcing them down to low lung volumes by all the mass of the chest wall. So we used a system here based around the FlexiVent, but modified so that a human can breathe in and out of a side port while a piston here is oscillating, and we measure impedance in the usual way, just as I did before. We don't go from 1 to 20 hertz, though. We go from 5 to 20 hertz because someone has to be able to breathe, and they're breathing down in this frequency range. So we don't want to have spectral overlap between where they're breathing and where we're measuring impedance. So we limit ourselves from 5 to 20 hertz, which means that that constant phase model I mentioned before is not really identifiable. We have to go with models that are just elastic units on pipes. And it turns out, again, we have evidence for this, that a serial model where we have a distal parenchymal compartment, a proximal, probably airway and upper airway compartment with associated resistances, and the inertance of the gas in the central airways is what we need to describe this. And the shape of the impedance is shown by the circles, and the fit is shown by the lines. And one of the popular ways of characterizing this empirically is to look at the area under the curve from 5 Hertz up to the resonant frequency as a sort of a generalized measure of how stiff the lung is. And we've also been doing a similar thing with resistance. The final thing I want to say is that when we looked at human asthmatics with this form of asthma, we got quite a striking result. And what we're showing here on the horizontal axis in these 4 panels, 4 groups: lean controls, lean asthmatics, obese people without asthma, and obese people with this late onset non-allergic asthma. We got them to take a big breath, go on the mouthpiece, and then just relax while they breathed out through a high resistance. So the lung volume came down to functional residual capacity pretty slowly. So this is total lung capacity down to functional residual capacity. What we're tracking here is the stiffness of the lung as they go down. And there's a bit of a decrease at high lung volumes in all cases because the lung tissues are stretched close to total lung capacity and hence a bit stiffer, and then they come down. You get a little bit of an increase towards functional residual capacity in the 2 lean groups. But in the obese groups, you get this massive upswing in elastance. And I think the only way to reasonably interpret that is that you're getting a substantial degree of collapse of the lung periphery. Probably because these poor folks, when they come down to their resting end expiratory lung volumes, functional residual capacity, it's lower than normal. It's actually below their closing volume. And so because of the weight of the chest wall, they're getting a great deal of collapse of their airways, which has all sorts of serious implications for how do they sleep, how do they get properly oxygenated during the day. That can give rise to a host of other problems. And we're now looking at using positive pressure to reverse this. But anyway, I'll end there. Just in summary, talked about system identification, also called inverse modeling, and you have to use simple model structures with few free parameters to do that successfully. And you hope that the parameters represent physiological quantities of interest. And I should mention that there are invariably model ambiguity issues here, because I showed a 2-compartment model there with the 2 compartments connected in series. How do we know they're not connected in parallel? Well, in fact, we don't. Kind of inferring on the basis of the parameters we estimate, we think it's that series arrangement. We don't really know that that's the way it is. And this is something that you just have to struggle with and try and do the best you can. Simulation or forward modeling can use very complicated models, but as I think I showed or I tried to show, they can create virtual laboratories in which you can test the feasibility of ideas like, is it narrowing of airways? Is it de-recruitment of lung spaces? At what level and so forth? And forward inverse modeling together make a very powerful combination in many cases. And now we are linking structure to function in mouse models of asthma and more recently in human patients with asthma. And with that, I will thank you. A few acknowledgements of my esteemed colleagues there and some support from the NIH. Thank you.
Thank you very much, Jason, for this nice talk. Also, we're still on time, so Dr. Bates is a professor of medicine at the University of Vermont. So thank you again. Next speaker is Dr. Rama Mukamala. He's a professor of bioengineering at University of Pittsburgh. So Rama, whenever you're ready, tell us if you have control of the screen or if Jason released it for you.
No, I did. I've released it. You should be good to go.
Okay, thank you, Jason. Rama, are you good to go?
Can you hear me?
Now we can. Now we can.
I don't know if you're hearing me through this or not. This is not mine. I just got it from a colleague because they're drilling here, and it could create. I don't think it's working. Let me try without it. And here, can you can hear me? Can you hear me better now?
Yeah.
Let me just see
the same thing. Same thing. Yeah.
Let me see how. Oh, it's the same thing. Okay. Yeah. There's drilling here, and there's this background, and it's randomly coming, and yeah. So hopefully we won't get much of that. But
Okay, we cannot hear the drilling, so I think but we can hear you very well.
Okay, well, right now it's not there, but hopefully you don't hear it. I'm very sorry.
Okay.
Yeah, I don't know about this headset. But should I
Okay.
go? Should I go ahead?
Yes, please.
Okay, hello. Many thanks to Dr. Chavarti for organizing this mini symposium on clinical system identification and inviting me to participate. I've been interested in applying system identification to the cardiovascular system. So my talk will be a little different than the last three. And I've been interested in this since my graduate school days. And back then I took a course on system identification that was based on Dr. Loon's book. Nick had mentioned that book. And back then I applied system identification to probe how the brain controls the circulation. And early in my independent investigator career, I started to apply system identification, mainly of the blind variety, for the purpose of advancing hemodynamic monitoring. And so in this talk, what I wanted to do is I wanted to tell you a story about how my collaborators and I translated system identification to seamless cardiac output monitoring in the operating room in the intensive care unit.
Okay.
So before I begin, I should mention that I have financial conflicts of interest with this presentation. As I'll explain later in this talk, I am a principal of Raytheon Medical in Valhalla, New York. So
Right next door.
So cardiac output. Cardiac output is the amount of blood pumped by the heart per unit time, or it's the total blood flow rate in circulation.
We cannot see your presentation, right?
We do not see your slides.
You don't see?
No, I don't see your slides.
Huh, that's weird.
I thought you were going to show it in a
I thought you were just introducing before you actually share a slide.
Oh,
We haven't seen any slides yet.
that I don't get it.
We actually don't see any desktop. We just see a black screen. So
How's this? Something's weird with this. Something happened all of a sudden to my, okay.
try sharing again.
Now we see you full screen. Try sharing again. Yeah, it says Rama Mukamala has started screen sharing. Double click to enter full screen mode.
There's no slides.
But there are no slides to be shown.
How's this? That's never happened. Can I log out of Zoom and come back in?
Sure.
Yeah.
Wait, okay. In the meantime, thank you attendees for your patience. Dr. Mukamala will log out, as he said, and will log back in, and hopefully we can see his slides. Thanks for your patience.
Yeah, sorry. Let's hopefully this will work.
Okay.
Do you see my screen?
Yes, now we can.
Maybe it was putting that headset. Do you see it in full presenter view now?
Now we do. Yes.
Do you see my next slide?
Yeah.
Okay, good. Sorry about that.
No, it's okay. It's okay.
Yeah, I was just
Okay.
saying that I wanted to mention I had financial conflicts of interest with this presentation, and I'm a principal of Raytheon Medical in Valhalla, New York. That was my disclosure.
Okay.
So yeah, cardiac output. Okay, good. We're cardiac output. That's the amount of blood pumped by the heart per a unit time, or it's the total blood flow rate in the circulation. And it's a major determinant of oxygen delivery to the body, and therefore it's a cardinal cardiovascular variable. Cardiac output is typically about 5 liters per minute, but it can change dramatically. For example, during exercise, which is normal, or in circulatory shock, which is not. So cardiac output monitoring is very important for managing high-risk patients in the OR and ICU because they frequently develop hypotension leading to circulatory shock. So cardiac output monitoring can provide an early warning of shock. So for example, in the early stages of bleed, mean arterial blood pressure is maintained even while cardiac output is falling due to compensatory physiologic mechanisms. While obvious hypotension will eventually occur, it's often too late to intervene at this point. So cardiac output, but not arterial blood pressure, could give an early enough alarm of the need for a life-saving intervention. So cardiac output monitoring is also helpful in determining the cause of shock. For example, it can distinguish high output septic shock versus low output cardiogenic or hypovolemic shock. Perhaps even more significantly than that, cardiac output monitoring can guide perioperative fluid therapy. So during surgery, major surgery in particular, blood loss is common. And so it's very obvious to give fluids, but over-resuscitating the patient can be harmful. Cardiac output monitoring indicates when to cease fluid therapy. If a fluid bolus causes cardiac output to increase, then the patient is on the steep part of the Starling curve and could benefit from more fluid. But if the fluid bolus causes no change in cardiac output, then the patient's on the flat part of the Starling curve and could be harmed by more fluid. No more than half of fluid boluses given in the OR and ICU result in an increase in cardiac output. So a meta-analysis of 29 studies of high-risk surgery patients showed that CO cardiac output-directed fluid therapy reduces mortality, morbidity, and length of hospital stay. And cardiac output monitoring can likewise guide fluid therapy in patients with COVID-19 induced acute respiratory distress syndrome in the ICU. So the problem is that there's no good way to measure cardiac output. For many years, cardiac output was measured regularly with the pulmonary artery catheter based on thermodilution principles. However, randomized controlled trials showed that the invasiveness of this device, which causes infection and other complications, offsets the benefits of cardiac output monitoring. And as a result, this method is mainly limited to liver and cardiac cases today. Ultrasound is a less invasive method, but it requires a trained operator to frequently reposition a transesophageal Doppler probe, which continually moves with cardiac and respiratory activities, or steadily direct a non-invasive Doppler probe. Impedance cardiography is non-invasive and automatic, but it requires a special set of 8 current injecting electrodes that are not part of the standard of care. Furthermore, this method may not be reliable in many high-risk patients, probably due to lung fluids. And as a result, ultrasound and impedance cardiography are being used even less than the pulmonary artery catheter. So an alternative method is pulse contour analysis. This method continuously computes cardiac output by mathematical analysis of the peripheral arterial blood pressure waveform that is already being measured via minimally invasive arterial catheterization in millions of OR and ICU patients every year. In this way, seamless cardiac output monitoring may be achieved in many high-risk patients. So pulse contour analysis methods have actually been proposed for over 100 years. And there are 2 classic methods. One of these methods assumes that cardiac ejection occurs instantaneously so that the stroke volume may be equated to the pulse pressure times the total arterial compliance. Cardiac output can then be estimated to within an arterial compliance scale factor as pulse pressure times heart rate. The other method avoids the instantaneous cardiac ejection time assumption by assuming a Windkessel model of the arterial tree. This was a model shown in the previous talks for a different application. This simple model accounts for the arterial compliance and the systemic vascular resistance and predicts that arterial blood pressure will decay like a pure exponential during diastole with a time constant equal to R times C. So an exponential is fitted to the arterial blood pressure diastolic decay to estimate the time constant, and cardiac output is then estimated to within an arterial compliance scale factor as mean arterial pressure divided by the time constant. These classic methods, they form the basis of current pulse contour analysis devices on the market. However, these and earlier methods, pulse contour analysis methods, generally ignore wave reflection, which profoundly impact the shape of peripheral arterial blood pressure waveforms. That is, when the heart ejects blood, a pressure wave is initiated that travels through the arteries. When this wave reaches the small arteries, a significant part of the wave is reflected back towards the heart. As a result, the actual blood pressure waveform at any given site in the arteries arises as the sum of the forward and backward traveling waves at that site. Since wave reflection occurs mainly in the small arteries, there is little time delay between the forward and backward waves in the periphery. So when you add the backward wave to the forward wave, the peripheral pulse pressure increases a lot. On the other hand, the forward and backward waves in the central aorta are shifted in time. And that is the time it takes the forward wave to travel to the periphery and return back to the heart. So because of this time shifting, adding the backward wave to the forward wave has much less impact on the central pulse pressure. So for this reason, and perhaps counterintuitively to you, pulse pressure becomes progressively amplified with increasing distance from the heart. And due to a similar mechanism, exponential diastolic decays, which may be present centrally, become progressively obscured and are absent generally in the periphery. So furthermore, the magnitude of the backward wave relative to the forward wave increases with systemic vascular resistance. As a result, peripheral pulse pressure increases with vasoconstriction and decreases with vasodilation. So in these ways, confounding wave reflection could compromise the cardiac output measurement accuracy of available pulse contour analysis methods. So our idea was to employ system identification to overcome the confounding arterial wave reflection in peripheral arterial blood pressure waveforms. The waveform is specifically analyzed over multiple beats rather than just the traditional single beat in order to determine the pure exponential decay that would eventually result if the heart abruptly ceased to beat. So more specifically, the arterial blood pressure response to a single heartbeat is estimated from the waveform. Then the Windkessel or RC time constant is determined by fitting an exponential to the tail end of this response once the faster wave reflections vanish. And finally, cardiac output is computed to within an arterial compliance scale factor as mean arterial pressure divided by the time constant. So system identification is specifically applied to determine the single heartbeat arterial blood pressure response. First, a waveform indicating the heartbeats is formed as an impulse train, in which each impulse is located at the onset of upstroke of each arterial blood pressure pulse, and each impulse is scaled by the ensuing pulse pressure. Then, an impulse response is identified, which when combined with the impulse train input, optimally fits the peripheral arterial blood pressure waveform output. By definition, the impulse response represents the arterial blood pressure response to a single heartbeat. So to implement this multi-beat analysis method, the impulse response is parameterized with a pole zero model. The autoregressive exogenous input or standard ARX model is specifically used. This model uses the system poles to also color the white residual error, but it's convenient to identify. For a fixed model order N, the parameters of the model or coefficients of the model are estimated analytically via the linear least square solution. And the model order N is determined by minimizing the minimum description length criterion. I'm sorry, one moment, please.
That's okay.
I think you might be hearing some background noise. So
I can't, but no, I think it's fine.
Okay, so this method right here, this might maybe reminiscent to some of all pole modeling of voice speech. And so we therefore tried to justify the assumption of a pole zero model based on physical modeling of the arterial tree. A popular arterial model is a parallel connection of M ideal lossless transmission lines terminated by 3-parameter Windkessels. Each line represents the wave travel path between the central aorta and peripheral artery. A line accounts for the inertance and compliance of the large arteries. It therefore has constant characteristic impedance and allows waves to travel with constant pulse transit time. Each load represents the arterial bed distal to the peripheral artery. A load accounts for the resistance and compliance of the small arteries. It therefore has frequency-dependent impedance while matching the line impedance at infinite frequency. So waves traveling on a transmission line in the forward direction are reflected in the backward direction at the terminal load. And the blood pressure and blood flow rate at any point on a line arises by adding or subtracting the waves after time shifting to account for the pulse transit time. So in this way, this model is able to predict the progressive distortion that blood pressure and blood flow rate waveforms undergo with increasing distance from the heart. Also, the transfer functions relating blood flow rate and blood pressure waveforms at various sites on the transmission lines may be readily derived from this model. And furthermore, consistent with our underlying idea, this model reduces to the Windkessel or RC circuit model as frequency declines. Since large artery large artery characteristic impedance is usually in the range of 0.1 millimeter of mercury per millimeter per second, the inductors in the line short before the capacitors in the line open. And further, since the small artery compliance is much less than the large artery compliance, the load capacitors open before the line capacitors. So at low frequencies, each line becomes a parallel connection of capacitors while each load becomes a series connection of two resistors. All of these elements may be lumped together to arrive at the RC circuit model shown here. So this transmission line model reduces to this model at low frequencies, which is consistent with our overall idea. So the method again assumes that the arterial blood pressure waveform arises as an impulse train input convolved with a pole zero system. The system can be thought, this system can be thought of as a cascade connection of three transfer functions relating the impulse train to the total blood flow rate or cardiac output, the cardiac output to the central blood pressure, and the central blood pressure to the peripheral blood pressure. The impulse response of the first transfer function is proportional to 1 beat of the total blood flow rate waveform. We've empirically found that this waveform can be represented as a second order pole zero system. And then, according to the transmission line model that I showed in the previous slide, the second and third transfer functions can also be represented as pole zero systems. So when you take the cascade connection of all three of these transfer functions, you get a pole zero system. In this way, the assumption of our method of a pole zero model rather than an all pole model is justified by the physical transmission line model. So we performed several studies to investigate the cardiac output measurement accuracy of the multi-beat analysis method. And here is a summary of those studies. The method was calibrated with a single independent cardiac output measurement, and it achieved a cardiac output error in the 15% range against manual or invasive reference cardiac output measurements from animals, healthy humans, and many critically ill patients. And it was also able to track cardiac output reductions induced by central hypovolemia. So the central hypovolemia study was most compelling. It involved application of a laboratory procedure called lower body negative pressure. In this procedure, negative pressure is applied to the abdomen and lower extremities through a pressure chamber with an airtight seal. And this causes blood to pool into the lower body. A chamber pressure of -40 millimeters of mercury causes about a 1 liter shift of blood from the upper body to the lower body. And as a result, cardiac output markedly declines, but mean arterial pressure is maintained. This is almost the same mean pressure. So the cardiac output estimate of the multi-beat analysis method in red correctly decreased with increasing lower body negative pressure and then returned to baseline following recovery from the laboratory procedure. But by contrast, the classic pulse pressure times heart rate method in magenta incorrectly increased with the increasing lower body negative pressure. And this incorrect prediction occurred because the compensatory vasoconstriction increased the peripheral pulse pressure. So I translated this research to industry by co-founding Raytia Medical. This startup company is backed by the Pritzker Block family office. The company has developed the Argos device to implement the multi-beat analysis or MBA method for seamless cardiac output monitoring in many OR and ICU patients. The company has received FDA clearance and CE marking to market the device in the US and Europe. And the device is now being used by various hospitals in the United States. So the MBA method of the Argos device takes the radial at the wrist or femoral at the groin arterial blood pressure waveform as input, and it outputs either 20-second or 5-minute averages of cardiac output every 5 seconds. Since arterial compliance varies inversely with arterial blood pressure and age, and positively with body size, the method includes a proprietary formula to estimate arterial compliance from arterial blood pressure and basic patient information. Inclusion of this kind of formula means that this and other pulse contour analysis methods are best used for tracking cardiac output changes rather than measuring the absolute cardiac output level. The identification of the impulse response was also re-optimized by the company, and the final specific procedure is proprietary, just like this formula for computing arterial compliance. In addition, the method includes heavy front and back end processing to, for example, detect the heartbeats and common waveform artifact and output cardiac output values only when the data are deemed reliable. The Argos device and its MBA method has now been assessed in clinical studies, and I'll give you a summary of the 3 most important studies to date. So first is the FDA study. This study included 40 liver transplant or cardiac surgery patients in the OR or ICU. And the Argos device was compared to the market-leading Edwards pulse contour analysis device using pulmonary artery catheter thermodilution as a reference. And this was done during surgical landmarks in the OR and periodically in the ICU. So here are the Bland-Altman plots of the absolute cardiac output values and the concordance plots of the percent cardiac output changes between consecutive measurements for the Argos device versus pulmonary artery catheter thermodilution and the Edwards device versus pulmonary artery catheter thermodilution. You can see, for example, visually that the cardiac output change data points for the Argos device are more on the identity line than the Edwards device. Overall, the Argos device was statistically more accurate than the Edwards device in measuring significant cardiac output changes and also low cardiac output values, while showing comparable accuracy otherwise. So second, a study in Hamburg, Germany included 58 off-pump CABG patients. And here the Argos device was compared to the same Edwards device using pulmonary artery catheter thermodilution as a reference before and after clinical interventions, such as fluids, vasopressors, and inotropes. And here are the Bland-Altman and concordance plots for the Argos device versus thermodilution and the Edwards device versus thermodilution. You can see that the intervention-induced cardiac output change data points for the Argos device are likewise more on the identity line than the Edwards device. And overall, the Argos device was statistically more accurate than the Edwards device in measuring CO changes as well as absolute cardiac output levels. Third, a study in Paris included 58 neurosurgery and abdominal surgery patients. And here, the Argos device was compared to reference transesophageal Doppler ultrasound before and after fast-acting vasopressor boluses and fluid infusions. Here are the Bland-Altman and concordance plots of the intervention-induced cardiac output changes for the Argos device versus the reference device. The Argos device tracked the cardiac output changes during both interventions well. For example, the direction of its measured cardiac output change was the same as that of transesophageal Doppler 93% of the time. So in sum, system identification can be helpful for cardiac output monitoring in the OR and ICU. Finally, I would like to thank my academic collaborators, as well as sponsors, and of course, Raytia Medical and their clinical investigators for their crucial roles in this story. That's all I have. Thanks for listening.
No problem. Thank you very much, Rama, for this talk and a real usage of clinical system identification that made it into a successful product. Professor Mukamala is a professor of bioengineering at the University of Pittsburgh. Okay. Yeah, Rama, you're looking at me as if you want to say something?
No, I'm good.
Okay. So, gentlemen and ladies, let me, so now we have an open discussion time. I don't know if the attendees can see the panelists. We cannot see the attendees, but I bet and I hope that they can see us. Then again, maybe I hope for them that they will not see our faces. But if you can see us, this is an open discussion, and it's about the topics about clinical diagnosis in the 21st century. And if we want to discuss any topic relating to development or application of clinical system identification. If we have questions from the audience, please write them, because I don't think the audience can talk like this. Write them on the chat box and I'll read them out loud and we'll try to answer them. Otherwise, we will go around here and we'll discuss the topic that we have in our mind. Okay, should we take a minute break or 2 minutes bio break maybe? Because we've been at it since 9:15 a.m. So please come back, don't disappear. We'll take a couple of minutes breather space. 2 minutes exactly. Merci, thank you. Okay. It's 11:17 now, so we'll come back at 11:19. Hello there. You can hear me okay? Okay, thank you. Thank you for the confirmation, Dan. Okay, so attendees, thank you for sticking around. I hope you have used the break as well. Okay. So first of all, let me see if we have any questions. We have a question. Can everybody read these questions or only me? I don't know, but I will read, and if everybody can read them. Can the panelists discuss problems associated with generating an appropriate input signals for clinical system identification? So problems associated with generating an appropriate input signal in the clinical world. Anybody would like to take that?
I can answer that a little bit. For instance,
Wait, you are muted. Okay,
no,
you're fine.
can anyone hear me? Everyone hear me? Yeah, like for instance, in my problem, like in the aim that I had to estimate the lung parameters, I followed the ISO test to generate my input signals to get a response from the system.
But from the so you're talking experimentally though.
Yes.
But maybe they meant clinically. I mean, in the hospital, how would you generate? So what do you need to do to generate an input signal? And I think, yeah. Go ahead, please.
I guess there's a couple of issues. First of all, is practically how do you generate it, which is just an engineering problem that's specific to every situation. But to take the measurement of lung mechanical impedance as an example, the input signal is critical for determining what kind of information you get, because the biological systems we study are way more complicated than any of the models that we use to describe them. So, for example, in the case of measuring lung impedance, you typically apply a broadband in a multi-frequency signal in flow. But the information you get back depends critically on what frequency range that encompasses. If you go, from as low as you can go up to about 2 hertz, you get information about the lung tissues. If you go from 5 hertz up to 20 hertz, you get information about the airway tree and the inerts of gas in the airways. You can go up to acoustic frequencies, in which case you get different kinds of information. So, what you learn about a system depends very much on how you perturb it. I think that's an important principle.
Okay.
I think it's an excellent question. It's really on point. And usually the data we collect are very limited in information, and so you can only estimate a few parameters. But when I was a graduate student in Richard Cohen's laboratory at MIT, he developed a randomized breathing protocol and asked the subject to breathe in a random way according to a sequence of auditory tones. And that's not applicable for patients in the OR, but it could be applicable in other clinical situations that could help for cardiorespiratory application.
Yeah. Thanks. I mean, typically we would like to use whatever input signal is available in order to estimate what is not available, basically. So this is the ultimate goal. And breathing in, I mean, giving an input signal as close to an impulse as possible, like the impulse strain of Dr. Mukamala, is good because it excites a lot of the frequencies, like Dr. Bates said. So, but we cannot expect this from the patient, but we know that when we collect the input signal, what we would like it to be, and then act accordingly, basically. Yeah.
I will say one thing about the impulse. I mean, in principle, the impulse contains all the frequencies, but from a signal to noise perspective, it's not usually the best way to go because the frequencies are hyperbolically spaced amplitude-wise as you go up. What we do in the lungs, which seems to be much more robust, is develop composite signals that contain specific frequencies over the range of interest with carefully tailored amplitudes, so that we maximize the signal to noise at every frequency we're interested in. So you end up getting this sort of pseudo-random wiggle going in. I think I showed an example of that. So the spectral content in terms of the amplitude as a function of frequency, if you're doing classic system identification from a practical point of view, a signal to noise point of view, can be very important.
I see. Okay. Very good point. Another question was, since this symposium made so happen, I mean, this is the first symposium on clinical system identification, and we happened to pick people from the respiratory field and the cardiac field. So one question is, can it be applied outside these two fields? And the question is, sure. We did an application on renal. Here, it is not. It hasn't made it into a product yet, but certainly you can. Any dynamic system, as Sid said in his talk, where you have input and output, you can potentially do system ID on. So that would be the answer for the. Jason, do you have anything to add to that, or Rama, or Dan?
Yeah, I would agree. I mean, in principle, you can do it on anything. Historically, the lung has been a favorite organ for people to do system ID on. It's probably why I got involved with it actually early on. And the reason is because you can get at it easily. You can measure pressures and flows of the mouth. You can measure gas, as Dan does. And the heart to a certain extent as well, because it's easy to measure blood pressure. It's not easy to measure cardiac output. But when you're talking about the kidney, you can measure urine output, but that takes a few days to get a good number of data points. The brain, modern medical imaging has changed the field on all this, because now we can look at any of these in detail up to a certain point. But in terms of input-output relationships, various systems vary quite a bit in how easily you can gain access to them. And I think that's one of the things that determines the utility of this, the practical utility of this as a function of the organ system.
Yeah, I see. Another interesting question. Thank you, Jason. Another interesting question from the audience, Jean Gillen. Thanks for the interesting talks. The general question to all speakers: how do we medically train professionals to receive your methods? How do we make them trust the math? And would they be hesitant and eager to collaborate? Very good, loaded questions, but maybe we can start with the first one. How do we medically train professionals to start accepting these methods? Yeah, good question. I don't know how yet, but it's. Symposia like this and inviting MDs to it, getting the buy-in from the MDs to just show them, as with the Argos device and other work that Jason and Dan are doing, and here we're doing. So we're all, as if in our own ways, trying to put forth products in order to do the diagnosis-based, accurate diagnosis that happens to be based on a mathematical model that we call clinical system identification. So in time, we have to maybe have a program to convince people, or to do demonstrations widely for the clinical field, maybe make it part of an AMA conference, American Medical Association conference, so that they can carve out a session just for this. I'm thinking out loud, but Dan, Rama, Jason, Sid, please feel free to contribute. But it's a good loaded question.
I can add a bit, sorry.
Yeah, go ahead, Dan.
Okay, fair enough. Well, I think there's many answers to that question. It's quite open-ended, but I think my overall impression is people are open-minded and curious and very collaborative, but also, and rightfully, of course, critical into the assumptions of any technology that you want to introduce. But I think at least our experience with the ALPI technology has been that that experimental studies, observational studies are very welcome, and medical staff are generally very interested in the possibilities that system identification poses, the possible extra information or more personalized information that can help them guide their therapy. So that's at least been my experience up until now.
Rama, yeah, go ahead.
I was going to say, if you put the output of the system identification in a form that the physician understands, for example, cardiac output, then all you have to do is show that that method, measures cardiac output. But let's say you're defining a new physiologic parameter through system identification. Maybe it's the system gain or the system phase, something like that. Then I think it's a long road to get a physician to accept it. And what you would need to do is you would need to show conclusively that that new parameter helps guide therapy so as to improve outcomes. And if you do that through published papers and are probably randomized controlled trials, then I think they would accept it, but it's a long road.
Yeah.
Yeah, I would agree with that. I think Rama hit the nail on the head. The key to real acceptance is that it changes clinical practice. The thing you're measuring can be as interesting as you like, but if it doesn't cause the physician to change what they're doing to the patient, then at the end of the day, they don't care. They may be interested, but it's not going to influence how they treat the patient. But if you give them something that actually influences their decision, then you're onto a winner. And in the case of the forced oscillation technique that I've been talking about, or measurement of impedance. And by the way, I should say, I was remiss in not declaring my conflicts, and I'll take the opportunity now to say that I've just recently become a consultant for a company called Respiratory Sciences in Minnesota, which is looking at commercializing a system to do this. Anyway, the thing that the measurement of impedance is up against is what's called spirometry, which is the conventional way of measuring lung function in a clinic, where you take a big breath and blow out as hard as you can. And that's been used for decades and is the standard of care. And until you can show that impedance gives physicians something that influences their management that they can't get from spirometry, or that they get more easily, or has distinct advantages, or can be used in patient groups that can't do spirometry, all of which, by the way, are true. But if you can get that accepted, then you're on the way to having it used, to making an impact.
I see. Okay. Yeah, thank you, Jason, for the comment. And yeah. Okay, another question from Professor Jin Ohan from the University of Maryland. Thank you for joining this symposium. He said that the quality of parameter estimates can heavily depend on the richness of the data used for system ID. Hence, the use of data obtained from real clinical settings, which may be sparse in information contents, may present challenges in deriving accurate and reliable parameter estimates. Is there any practice in the domain of clinical system ID to ensure the fidelity of parameter estimates derived from real clinical data? Another very good topic, and from our small example here, also for respiratory application, we're trying to deal with data as it comes in after you filter and stuff, and so any information we can extract, we can squeeze out of it. It is a problem plaguing this field also, but not all identification methods have to use continuous and very accurate data. Some of them you can use sparse data, and it depends what you're estimating, really, basically. I mean, urine output, as Jason was saying, this is not available continuously, though some companies are working on that. But you can get some estimates even from a steady state model, where the data can come in very sporadically. I'm sure you know that, Professor Hahn, but it's an example I can think of, and we are dealing with currently. But any other comments from Jin O's comments? Rama?
Yeah, I mean, that's a good comment as well. I don't know if this answers the question, but I mean, if we define clinical system ID just for the moment as system ID that's used in clinical practice, then, the practice in the domain is regulated, by the FDA and these kinds of things, and they will force you to do a clinical study, involving real clinical data to prove that your system ID based device works. And so I guess that's the practice in the domain. So that will be, if it works in that study, then therefore it's, your parameter estimates are good. I don't know if that answered your question.
Generally, I think, oh, sorry. Generally, I see the Bland-Altman plot that's also been presented several times from the different panelists here today is very much used as the method in line for showing it. It requires, of course, that you have a reference technique to compare to. Often that reference technique is expensive in carrying out, and the new method is easier to use, and that's the motivation for introducing it. But generally, a Bland-Altman plot as well as correlation analysis are kind of the methods to go to verify that your parameters are actually in line with the clinical data.
Yeah, I might just add a thought to that too. Is I agree that with Dan, the Bland-Altman plot is the sort of standard for doing this, and it's very useful. One thing to bear in mind, though, is that a statistically significant correlation between two variables does not mean that one can be used usefully as a surrogate for the other. And this is a mistake a lot of people make. I mean, they just leave it at the correlation, say, look, the R is greater than such and such, we're done. But you can still have a huge variation about 1 point estimate with a decent scatter, even in the case of a significant correlation. So if you really want to be able to measure A when you're measure A and all you can get is B, you've got to ensure that a measurement of B is giving you a clinically useful estimate of A. And that's really up to the user and what clinically useful means in that particular case. The other thing I'll point out too, sorry. Yeah, no, I'm just going to find it related to this is that, like I said, most of my work is done in animal models, and we are now applying some of these in patients. And it's a continuous source or continual challenge, if you like, that you can get great data in animals. But unfortunately, when I go to patients, I can't anesthetize, paralyze, and tracheostomize them. They just don't go for that, And so the data I get is just not nearly as high fidelity as I get in a mouse, and you just got to live with that.
Mm-hmm. I just wanted to add that Jason's point with the correlation analysis is right on spot, and Bland and Altman in the original paper very nicely showed that never just do correlation analysis. It's a fair point.
Yeah. I mean, yeah, correlation is not causation, but sometimes it is. So you have to be a good judge of that. Another question from Valentin Sidersky to everyone. Actually to Dr. Mukamala's talk, is that can we use continuous non-invasive arterial blood pressure measurement for your method, Rama?
Well, that lower body negative pressure result I showed, that was a non-invasive blood pressure measurement. But the Argos device, so the answer is yes. Yeah, you can do it in theory, but the Argos device is not approved for a non-invasive blood pressure input. But there are other devices that can do it that are available on the market.
From the same person to the whole panel, cardiopulmonary exercise testing, CPX, is a standard clinical pulmonary exercise test that is equipped with O2, CO2 at the mouth, flow pressure, ECG, SpO2, blood pressure measurement. A phase in pulmonary therapy where there is a magnifying glass on diagnosis and parameter estimation. Has anyone investigated using system ID in this setting for CPX, so cardiopulmonary exercise? I haven't. I don't know, Dan, if in your group you guys did real-time parameter system ID during CPX?
we regularly do CPX, but as input for other uses. But I know that some groups have looked at the VO2 kinetics to understand the time response of any exercise perturbation. Not something we have done ourselves, but that's been done, I know.
Okay. From Jan Grashoff to Professor Bates, is the oscillation technique uncomfortable for patients? Could it be used in ICU patients?
It's not uncomfortable at all. You can detect that there's little oscillations and flow being blown into you, but it's extremely comfortable, and it most definitely could be used in ICU patients. In fact, it has been used in ventilated patients. It doesn't require any effort or collaboration on the part of the patient. So it can be used in very young children, babies even, or the very elderly and so forth. So therein lies some of its, in principle, key advantages. And that's one of the things that's being exploited by the current movement to get it used more in the clinic.
Mm-hmm. Okay.
So,
a question from Robert Kearney that I lost momentarily, but I will get it. He said that clinical adoption of system ID methods will likely require evidence that the methods improve patient outcome. Have any of the panelists carried out such a study? I mean, this is,
It's ongoing.
It's ongoing.
It's ongoing. Yeah.
In our case, if any, yeah.
I haven't done that. And I'll say hi, Rob. I know Rob very well. He was the chair of biomedical engineering when I was at McGill many years ago.
Oh, I see. Okay.
I haven't carried out such a study, but we're sort of beginning to think about such studies. And for example, I'll just give a quick example. One of the things that's commonly done in pulmonary function labs in hospitals, patients to be assessed for asthma, is they're given a methacholine challenge test where they're given sequentially increasing doses of methacholine, and the response to that is measured. And the way the response is measured now is you have to do spirometry, which means taking the biggest breath you can and blowing out as hard as you can for about 10 seconds. And typically, as you're going up through these doses, you may go through half a dozen doses of methacholine until you get a significant response. And it's standard to do 3 of these maneuvers after every breath. So by the time you finish this, you're pretty tired. I mean, you've been forcefully exhaling maybe 20 or 30 times. I had the pleasure of doing this, not recently, not because I'm asthmatic, because we were testing our equipment. And it's pretty unpleasant. Now, the forced oscillation technique or measurement of impedance, you just sit there and breathe quietly while this stuff is going on. And you may feel your chest is a bit tight. So it struck me for a long time that there's an application where just for ease of use and patient acceptance, it ought to have an application. It's something we could exploit, and probably we should, but we haven't done it yet.
Okay.
We have moved towards outcome studies, and it's a perfectly valid question, right? That's where we need to move. The issue for our sake, measuring gas exchange, is that we can't look at a single parameter per se, because the patients that we measure this on, and we want to guide mechanical ventilation, and are often multifactorial problems, and we are only addressing a single problem. But what we are doing is, and we have done, is to include these parameters in a decision support system. And there we've shown over 4 to 8 hours that using these models and system identification to guide decisions of therapy improves physiological parameters. So oxygenation, driving pressure, pH, and so on, without harming the patient, and also preparing patients towards weaning and extubation. But we have studies underway where we're looking at length of stay, which is kind of the next step in outcome studies. Mortality requires immense large studies to really show in ICU populations.
A follow-up question. Thank you, Dan. A follow-up question from Professor Hahn, especially for the sake of recursive and continuous clinical system ID based on real-time clinical measurement, is signal processing to remove noise and artifacts, etc. Can the panelists share some examples of signal processing for system ID from their prior or ongoing work? So what kind of signal processing do you do offline or online, I guess, in order to allow for system ID?
Yeah, that's a good question too. And you know, the thing about it is that you know, all these all these devices that are out there and commercially, they have to do the stuff, you know, do the signal processing for detections and removing noise and things like that, whether they apply system identification or not. And everyone has something front end processing and even back end, but it's all proprietary. And it's not. There are papers, of course, in the literature and so forth. But you know, in the case of the Argos device, for example, all that stuff is their proprietary knowledge. It's not published or anything. You can't go and download the code and run it for your studies or anything. And I think that's an area of need where we could put things, standard tools like that out there in the public domain that people could leverage instead of everyone reinventing the wheel over and over again.
Like in estimation of dynamic, the parameters of the lung, when you use pressure signals and flow signals, it would be good to get rid of sensor noise, since you're using sensor data from a product like a ventilator, and there can be external noises of the pipes being pushed or the patient coughing. All these things have to be taken into account when you're trying to do system identification to identify the parameters. You can also do things like, if you feel like the parameters are better estimated in certain phases of the breath or certain number of breaths, you can start extracting that data and start doing analysis on that to estimate the required parameters. This is how we've been applying it, or trying to apply it.
Just one more thing to add. Often, I don't see a lot of noise models in the model. So adding a noise model and with rich dynamics of the noise can improve system identification also. So you do the filtering that you can without affecting your system, but also you can identify some of the noise dynamics if you really want to, as part of the system ID process. Question from...
Can I just add to that?
Yes, please.
Classic estimation theory says that, you know, the model accounts for the deterministic variation in your system, and then you have this random noise, which has certain statistical properties and so forth. In my experience, that's absolutely never the case in biology. The residuals between a model and the data are always systematic, because there's something going on your model hasn't accounted for. Like, if you recall, one of the first slides I showed, the fit of the single compartment model to ventilated data, and the residuals were all cardiogenic oscillations. I mean, highly systematic. So you can't apply a statistical model to that noise. This is the heart hammering the lung. And this is because physiological systems are so complex. And now I'm not going to say it's never the case where you can model the noise in the classic way, but in my experience, it almost never happens. And so then you're stuck with trying to say, can I make my model more complex? And if I do, what does it mean? Or do I have to back off and leave it with a simple model and just accept the fact that I have systematic residuals, which are due to something I don't know that hasn't been taken into account? So it's a bit of a tricky business.
But those will be, Jason, won't they be then deterministic disturbances?
Yes, they are deterministic, exactly. So if that's what you want to call them, sure. But what I'm saying is you can't, in a situation like that, use a sort of classic noise model as is taught in the textbooks, you know? Yeah.
It depends. I mean, you have to understand the data and the sources of disturbances and noises. And if indeed, truly, you have no idea about the sensor, I mean, it's better to assume that it's white noise than not. But if you have intuition about the system, as Dr. Bate says, then yeah, it may be systematic, deterministic, and not stochastic noise.
Yeah,
right?
And actually, a practical consequence of that is that, you know, regression theory, particularly linear regression theory, has this beautiful theory that gives you covariance matrices on your parameters. But that's assuming random uncorrelated Gaussian noise, yada, yada, yada,
Yeah.
all that kind of stuff. And you can still estimate confidence intervals or standard deviations, but in the case of systematic residuals, which is invariably the case in my experience, you just have to say, well, it doesn't match the theory even close, so it's kind of an estimate of what the uncertainty range on the parameters is, but it doesn't conform to the theory.
Yeah. I know, so a question from Murat Demirer. Can we say recorded data based on physiological parameters non-integrable with phase and amplitude couplings and introduce singularities? Now, maybe I should have modified a little bit just the way it was asked, but yeah, can we so recorded physiological recorded physiological data due to its phase and amplitude, can it introduce singularities in our estimates? I think this could be the gist of the question. Yeah, it can. This is a short answer. But phase and amplitude, yeah, I don't know if someone else is more familiar, but I mean, to do like phase and amplitude, typically I would use a body plot, but that's assuming a linear system. So I don't know if they introduce singularities. I pass on this, I don't know. Maybe we can pick it up offline. A follow-up question by Dr. Kearney, I guess, Robert Kearney. Oh, you all can read it, so not only me?
Yeah, he sent that to everyone, yes.
Oh, so why don't you read it then?
Yeah, many physiological systems operate in closed loop. Can the panelists comment on what this might mean for clinical system ID?
Yeah, that's a cool question. And it's, I mean, all of the questions are good questions. So far, we just have to realize that when you're identifying something in the closed loop, at least in the Laplace domain, you want to identify G over 1 plus GH if it's all linear and you can represent it in transfer functions and stuff. So you will no longer only identify or estimate G, which is the plant, right? So so work out the transfer function for the closed loop and identify those parameters. You will have more parameters, maybe more complex structure, but I have, but it's not to an application of a real ventilator, but I have offline done that. So closed loop system identification, but I had to do it with the closed loop transfer function. Anyway, any comments from the audience? Yeah.
When I first started studying system identification, it was for how the brain controls the circulation, and that was done in feedback. And in those kinds of problems, we were interested in determining the feed-forward transfer function and the feedback transfer function. And it turns out that, it's possible to do that. I think you need at least, there has to be a delay in the closed loop path. You have the disturbances in each path. They have to be uncorrelated, and you need a parametric model. And if you have those three things, then you can accurately identify both the transfer functions and the feed forward and feedback path. There's also, and so I think, yeah, it's possible to do it. And it's a good question, and another good question by the same professor. And the other thing is, if you want to use non-parametric system identification, you have to inject a disturbance in the closed loop path. And that might not be practical for clinical system ID, but it is a way of, uniquely identifying both transfer functions in a closed loop path.
Okay, so for even a simple or simplistic model that can estimate 1 or 2 parameters, you want to implement it in a clinical scenario. Do we see any think any efforts or at the level of either the FDA or professional societies that need to happen in order to make this more acceptable or implementable out there? Or we go back to Rama's answer that if it's clinically useful, then they will use it. Why wouldn't they, right? Yeah.
Like if we give them the output in the most abstract form and in a parameter or a variable that they understand, then they will accept it more easily, which is what Rama said, which I agree with. If they do not know what it means, they're not going to accept it without criticism.
Yeah. So then is there, should we as a part of the professional society have a like systematic effort going on, or no,
Yeah.
like create a committee or do something that can push this forward, or no, let it be natural and eventually if you do something useful it'll be used type of thing?
I think we are making those efforts though.
Yeah, we are.
Yeah.
I mean, each one
person.
of the panelists individually trying to do that effort. So this what it there's like a lot of effort to do though. It's a lot of work and a lot of time has to be spent in order to apply that. So will we be helped with anything coming from above or no? Maybe like money from the government, maybe?
Well, from my side, I don't think the regulatory approval is a big beast to handle, but there's nothing in the approval that seems unfair or unwarranted. It's like introducing any measurement method will just fall in under the same umbrella. I think that we need to be able to document that the methods that we come with are accurate, reproducible, and usable in the context that we're saying they're intended to be used in. But it is, I think, for smaller companies a huge investment that they have to go through.
Yeah.
In terms of acceptance by the medical community, I mean, my experience is that my medical colleagues, who tend to be my closest colleagues, are very receptive to interesting ideas, and they're scientists like we are, and they're very smart. So at an individual level, getting our clinical colleagues interested in what we're doing has never been a barrier to me at all. I don't know what my colleagues here think, but one thing that can be a real problem is failed clinical trials. The big push these days is evidence-based medicine. Everything's got to be based, well, not everything, but they want as much of medicine to be based on the result of a positive trial, which on the face of it makes a lot of sense. But the problem is that clinical trials can only ask pretty basic, simple questions like, we have A versus B, is A better than B? And if the trial isn't done right, or it's done in the wrong patient population, and it comes back negative, that can kill an entire field for a long time, because then everybody says, oh, well, it's been shown not to be true. When, that's certainly not the case. And the right kind of adjustment to what was done might give a very different result. And so the power of failed clinical trials to kill a direction of investigation, I think, is a real problem in medicine.
Yeah. That's a bigger question than this here, but yes, absolutely. I recognize that as well. Definitely. Any sustained effort or something that we could do to address that bigger problem. But that is a big thing. This is about clinical trials in general. Yeah.
That's an interesting question here by Marianne Walter. Oh, sorry, Jason, you were talking.
It's a tough problem to deal with. It's a question of asking. It's a matter of asking the right question, I think. I've seen this, but I would do a lot of work in acute lung injury, ARDS and this type of thing, ventilator management of it, particularly at the experimental animal level. And this is a field where failed clinical trials have really shut out a lot of things that you'd think ought to work eventually if you could just get it right. For example, the application of positive end expiratory pressure, having a back pressure so the lung doesn't come down below a certain level. There have been a number of clinical trials trying to find out the optimum way to set that. None of them have come up with an improvement in a reduction in mortality, which is sort of gold standard everybody's after. And yet, no intensivist with half a brain would think of not using positive end expiratory pressure. I mean, that's complete insanity. And yet it's not in the evidence base. There's no guideline about how you do it. So what do you do with that? I don't quite know. I guess we haven't asked the right question yet.
Mm-hmm. What is the question from Maria?
Oh, yes. I just wanted to know all the panelists' view on this question because it's very interesting. When using system identification, the estimation result may depend on the numerical approach. What would be the guideline for choosing the numerical estimation method? And then there are two other questions, but we can first tackle this question. Like to me, I just think like if I use LSC, that it's a one-stop show, you get your parameter estimated. But then there are other ways to improve it using iterative approaches and so on and so forth.
I think it depends on the results, on the accuracy of your parameter that you're estimating and your usefulness clinically. The method, I mean, the physicians don't really care about this, and rightly so, and they shouldn't.
Yeah.
This is our job, this is our method to do, but we haven't done enough in order to conclude on which methods work better for which organ system ID or organ structure or something. I don't think we have enough history to allow us to opine or conclude on that, but that would be my own opinion. Maybe other people have different ones.
I was just going to say that in my experience, when you're dealing with clinical and physiologic data, the simplest method tends to work better. That might introduce some bias error, but if you go to a complicated model, you get a lot of precision error, and that precision error will be a lot larger. So it's basically a bias precision error trade-off. And to me, simple is in that kind of complex data works best.
Yeah. Let us make sure that we don't mix the two. So when we talk about complex model, it's model of the organ of the dynamic system. It's very different than the optimization method. You can use a simple optimization method with a complicated model, or a complicated model with, or a simple model with a complicated optimization method. So, right. So, yeah.
I thank you for clarifying that, Nick. I think what I meant was simple for both, for the model and the
Yeah, exactly. Yeah, I know. Simple is better, and you were numerically less likely to go into trouble and stuff like that. So if you can get by with describing the physiology simplistically more, I would take that route definitely. Added structure gives you the curse of dimensionality, and optimization hits you hard. But in optimization also, least square is just as good, and it could be the end solution, or you start with it and you get the results from least square, and then you use it for other more complicated iterative optimization solution as well. So the short answer to that question is I don't think we know yet which one, but from our burgeoning experiences, go simple first if you can.
If I may add a short comment on that,
Yeah.
My go-to is always to have a look at the objective function if the dimensionality of the problem allows so. So understanding the shape of your residual function, your fitting function, can really help to guide you into what methods are available to you. Do you have a lot of local minima? Do you have one global minimum that makes it very easy for you to find it? That allows for different numerical estimation methods. So my go-to would always be to, if possible, visualize my objective function, the error function that you're fitting with.
Yeah. I mean, would you use regularization or no, for example? I mean, it's hard to tell from the get-go whether or not. I know Jason used it, and he didn't tell us if he tried it without it or not, or why did you conclude that you needed an R of theta there? But anyway, so it comes maybe with experience, but yeah,
Sorry,
go ahead, Jason.
what example are you referring to specifically?
No, when you, in your talk, when you use the regularization parameter as a function of theta, the parameters, why did you choose to use such a term and not just the objective function without the regularization parameter?
I don't think I used regularization in my talk today. I have used it before, but I think it depends on the nature of the problem. Well, I mean, regularization.
Was it you or someone else? Yeah.
But I'll just say,
Maybe Dan's presentation, I'm sorry.
It was either
I think it was said that. But regularization, whether you use it or not, depends on what you expect the nature of the solution to be. I mean, it usually means smoothing the solution. So if you expect a smooth solution, like in the midget technique that Dan was talking about, multiple inert gas.
Yeah.
I mean, there are 50 compartments in the lung that are used, but there's only 6 different gases that they study. So I think you get retention and excretion for the 6 gases. So that's like 12 data points. Well, you can't estimate 50 parameters with 12 data. So you have to regularize just to make the thing work. And you assume, I mean, the assumption is that ventilation and perfusion distributions in the lung vary smoothly over the lung. If you don't accept that, it doesn't work, but it's a reasonable assumption at this point.
Yeah. Maybe it's not your talk. Sorry, I know. Maybe it wasn't you, Jason. Maybe it was Dan, actually.
Okay. But you know, one of the things about model fitting is the classic thing, and I've always, until recently, been taken this as a sort of the gospel, is that you need many more data points than free parameters that you're trying to estimate. You know, maybe an order of magnitude more in order to get robust estimates. If they're equal in number, then it's simultaneous equations, and if you have more parameters than data points, then it's an undetermined system. But interestingly, you know, the modern very hot topic of deep learning is exactly the opposite, because here now you have usually many, many more free parameters than exemplars in your training set. And so what you're finding is a solution amongst an infinite number that kind of does the job. And from a practical point of view, it still works, but it doesn't really tell you much about what's going on because it's just one of many solutions that will do the job. Kind of an interesting situation.
A question by Kashyap. Validation is a significant barrier and will need to be addressed as a complementary solution to bridge the gap and get the medical fraternity to buy into system identification. It is a data-intensive need. So any comments on that about validation being a barrier and will need to be addressed to bridge the gap?
Yeah, sorry if I do have a comment here. I think the word validation is a bit unfortunate, because to validate a model implies that you are demonstrating it to be correct. But to quote the famous George Box, all models are wrong, some are useful. So the idea that a model can be correct is actually absurd. So you can never validate a model. All you can ever do is demonstrate its usefulness in some way. And I think sometimes people forget that, and they think, well, how can you show me that this model is correct? And then they get upset when there are circumstances that come up where it doesn't work very well, which is inevitably going to be the case. So I kind of wish we didn't have the term validation, but well, what else would it be? Model usefulness demonstrator. That's pretty clunky.
Yeah.
You know what I mean?
Yeah. I hear you. Model usefulness process. but that's ugly.
That can be a performance metric by itself.
Yeah, so I mean, yeah, data is definitely needed. Any from your own experience, but again, just to answer the other person, just because this symposium we talk more about respiratory and cardiac, it doesn't mean this is where clinical system ID focuses. It is to help in diagnosis of any organ really. But this is our experience here so far, and hopefully if the reviews are positive, we can have more of these panels and symposia and just discuss these topics more, basically.
Yeah.
Any other final comments from the panelists? Maybe let's go one by one and just say maybe a one-sentence conclusion of a clinical system idea as you see it. Sid, you want to kick it off, and then we go to Jason, Rama, Dan, then me.
Yes, like I said in my presentation, I think that clinical system identification is a heavy need. Like it is where math and engineering can can support the medical field, and it's very important that we get that chance because we can improve and save patients' lives. Essentially, that's my closing remarks.
Go ahead, Jason. Any closing remark from you?
Well, I mean, I would agree with Sid. We've got to keep pushing ahead, and obviously we will. And I'd just like to point out that CT and MRI are both system identification methods. In the case of CT, you probe the body with X-rays and you use mathematics to infer an image about what's going on inside. Just think about the impact that has had on medicine. I mean, it's too big to describe. So the idea that system identification has yet to be proven as a useful medical tool is not correct. I mean, it's being demonstrated in Technicolor. So we're talking about, trying to do it in as many different ways as we can.
Mm-hmm.
Agreed.
Rama, any closing comments from you?
Well, I mean, I think that that was a really good comment. And I think like a good step, the big step forward for clinical system ID is if it could lead to new parameters that help guide therapy, like time constants, gains, things you can't get with non-system ID type analyses. If you could show that kind of thing, a new parameter could help guide therapy in patients, I think that would be a really good breakthrough, I guess, for what my interpretation of clinical system ID.
Mm-hmm, mm-hmm.
That's an interesting way.
I hear. Yeah, that's an interesting way to look at it. Definitely. Professor Carbing, anything from you? Closing remark.
Well, I'll just add to Jason's that system ID is all over the place in the hospital already, and I think that we now have several cases of system ID based on other system IDs going on, and I think that whenever we get a new measurement technology, it probably includes a lot of system identification in it that may allow new options, new models, more advanced models that will give us new understanding. It'll be very interesting to see where the field takes us.
Mm-hmm, mm-hmm. I understand. My closing remark would be, thank you, Dan. My closing remark would be clinical system identification really just improves diagnosis. So if you are to think of one sentence before you leave this symposium, it is that. It is nothing more, nothing less than diagnosis, really. So the physician do it with using their eyes as the sensors and the tactile. They touch and they see, and they go through a model in their head and they conclude on something for diagnosis. So clinical system ID is to complement or to assist in that, nothing more, nothing less, basically. So, okay, so we're coming to a closure a minute early, but it's okay. Thank you very much, all of the attendees, and thank you very much, all the panelists, Sid, Jason, Rama, Dan, for this. I really appreciate it, and I'm sure that the community at large appreciates your knowledge and contribution into this. And yeah, let's keep at it, and we see where the next phase takes us to.
Thank you for hosting it.
Thank you very much.
Thank you very much, and thanks everybody for listening.
Thank you.
Okay.
Cool. Okay. Ciao, ciao. Thank you so much. Bye-bye.